today, 26th of September, from 4 p.m. onwards. We as an endoscopist have a big role to play, and when it comes to infertility, it's our duty to see how best we can enhance the fertility. Today we have lined up 13 lectures of luminaries who are great surgeons, endoscopists, and they are teachers of teachers. We are going to learn from them endoscopic nuances in each fragment and each sections of fertility enhancement. And with me today, inaugurating this fertility enhancement and minimal access surgery is the guest, Dr. Rishikesh Paisar. We all know he is a wonderful human being, a humble man, and it is a very big thing for us that he has accepted to grace this occasion. He is the director of Bloom IVF Center. He is the president-elect of FOXY. He was the secretary general of FOXY. He was also the past president of Indian Association of Gynecological Endoscopists, ISAR, MOGS. I can go on and on. Many lifetime achievements award, orations to his credit. And I would like him to now inspire us with his 2 lines and inaugurate this wonderful workshop, which will be going till 9 p.m. Thank you so much, sir, for accepting this invitation.
Ranjan, for inviting me for this wonderful program. It is my privilege to be invited as the chief guest, and all of the people who are participating in this program are all great, accomplished people. Dr. Nandita is here. I can see Dr. Narendra Malhotra, Dr. Mahesh Gupta, and you also. And I really appreciate one of the things. Niranjan wears various hats. We all know that he has done a fantastic job in the last 3, 4, 5 months during the COVID period, disseminating knowledge. So many webinars he has had, and he has also been the professor of one of the main hospital, which is right in the middle of the entire action of COVID in the country, is the Sion Hospital, and he is there. I think 400 plus or 500 deliveries Sion Hospital has already done of COVID, and he is right in the middle of all this action. And I'm really, it's creditable for not only him but all our frontline health warriors who are literally, fighting in the jaws of death. So many of our children also are there as doctors, and every day is a lot of tension for all of us. And we are also proud of all of you, for fighting this disease. So without much ado, I would like to thank you and congratulate you, and wish you all the best. You are also, I think, going for the premier post of the treasurer of the IG, and I wish you all the best. You really deserve. So many years you have been teaching people over the years, and I feel that as you evolve and you become more mature, that is the right time, and probably this is the right time for you to go for the next level of things in life and teach. And always remember that most important thing is the patient service of patient. We are doctors are there for the service of the patient first and foremost. After that comes science, after that comes invention, after that comes progress, but service is the most important thing, which all the society looks at us as service providers more than anything else. And we have to understand that. Once we understand that, then there is no conflict between the doctor and the patient. So wish you all the best. I can see my friend Mahesh Gupta also there, and welcome Mahesh from Ahmedabad. And let's get on with the program.
Thank you, sir, for those inspirational words. And I appreciate that. Yes, we have done a lot of things in this last 6, 7 months. This journey has been very tumultuous with a lot of roller coaster ride, and all of us are really doing, the best of ability. I can see many people have put on weight, many people have lost their weight, many people are looking more energetic. And thank you, sir, for that energetic speech which you have given, and that is very going to inspire all of us. It has been a tough time for all of us, and we are actually last 20, 30 years, we have been just attending conferences, sir, and Madam Nandita and Narendra, sir. But this last 6 months has evolved and made us bookworms, and where we are reading, we are going through a lot of, the literature, science, attending webinars and trying to imbibe all this knowledge. So thank you so much for that wonderful, inspiring speech. Now I call upon our madam, Dr. Nandita Palshetkar. She is a wonderful human. I can say she is a goddess of Saraswati, Lakshmi, and you can say knowledge, power, wisdom, intellect, beauty, grace, and it is so nice that we see her today as an Amox president. She has already donned her hat as a Foxy president. And madam, you are very lucky, especially all your tenure happened before the corona started, and I was a witness to those wonderful programs and the conferences, the CMEs, the conclaves, and the workshops, and the PPP projects, and the government meetings, and so on and so forth. I can go. A lot of work and efforts you have done, madam, for the Foxy, for also the IAG, which you had taken in 2017. You were the president of MOGS 2016, where we come out with newer ideas of social
Thank you.
responsibilities. And I can go on and on. You are the
Thank you,
director of.
Niranjan. Thank
Yeah,
you.
thank you. Thank you,
Thank you.
madam, for blessing us today and being the guest of honor. I request you to please inspire us with your two lines.
I think this is a fantastic workshop which you've started, Niranjan, and especially fertility enhancing. I think that is a subject very close to my heart. And so when you told me that, will you please come, I was really happy, very happy that, today's era has changed. During the COVID times, we have switched over to this virtual platform. And I think a lot of webinars are happening. Some people are complaining it's too much. But believe me, I have had people call me up and say, we are so happy that you all are doing it because we are feeling lonely. We are enhancing our knowledge. And there's no other way. We have so many conferences in gynecology. So I think the webinars have replaced that. And I think all the KOLs who are giving so much time. Today you have 4 to 9. That's an amazing lot of people who are going to be talking and who are going to, educate the people about fertility enhancing minimally invasive surgery. I think that's a very, very important point because a lot of times we treat, I got a patient recently, a 29-year-old who had the whole ovary removed because she had a dermatitis, a laparotomy. So I think it's very important to communicate with people, to tell them what is required because there are still a lot of gaps in our knowledge all over the country. And I remember, Niranjan, I have come for all your inaugurations of your fellowships of endoscopy. I think you've been doing that fellowship in endoscopy for 10, 15, 20 years. I don't know how long you're doing it. But I still remember coming for each and every of your course program, talking to the people. So I think you've helped create a lot of endoscopists with good knowledge and good skills. And it's really fantastic job that you're doing. And I'm so happy to see Naren over here. Naren is busy looking at his phone, I know, but Naren, it's always a pleasure to hear you talk, and all these guys. Naren has especially inspired me a lot during my Foxy year with all the different aspects of social work which he and Jaideep did, and Mahesh. Mahesh is a good friend for a long, long time, and he did that wonderful Yuva Foxy for me. And I think, Mahesh, the best part of you was inclusiveness, which you really did and got everybody together. And of course, Rishikesh is my mentor, and I've learned a lot from him, besides IVF also. And really happy to have him here. And now he's taking over as the Foxy president. So thank you for supporting us throughout over here, and then taking in on the mantle last. So really appreciate that. And Niranjan, all the best.
Thank you, madam.
Thank you.
Thank you, madam, for those wonderful, inspiring
I have to get all of you back to the into major action in my year, and I'm sure Shanta Kumar is coming here. We'll all have you back. Without all of you, the Malhotras, the whole family of Malhotras, and Niranjan, Mahesh, Nandita, Rishma, Rohan, all of these people, and so many, Amaya, all of them, and all of you who are listening to us, you are welcome. It's like open. Whoever wants to come, whoever wants to contribute, you are always welcome. I am there with open arms. Thanks.
Thank you, Dr. Rishikesh Pai, for those comments. Dr. Nandita, I know the commitment which you have given, especially when you have flew from Jaipur while a TOG meeting was on in Bombay, then to Pune, then Mumbai back, and then to Jaipur back in 24 hours. I think no human being can do that. And that is what I am very, very thankful to you. You all are legends and inspire all of us, the younger generation, that how you can do science with travel, with education, with training, and at the same time doing clinical practice.
Foxy is
So
a
I
wonderful
think
organization. It inspires you.
yes, yes, yes. And I think, madam, I want to add just a half a 15 seconds. We are the only organizations where we as a gynecologist have different platforms, and every weekend we have so many programs which are involved. No other branch, even orthopedics or pediatrics or medicine, has got so many conferences. So when I recollect, I was just a houseman, and when I got introduced in my Mumbai Obstetric Gynec Society in the year of 91, and when I was exposed to those wonderful, five-star hotels where we actually learned, and we also learned clinical knowledge. It was amazing to see, and it has never stopped. But this corona is never going to stop us. We are going to beat this, and that is the reason we all have come together. That we want science to be imparted and the knowledge to be given to everyone. My whole aim is to endoscopy for all and endoscopy for every gynecologist. I would like to be thankful to our sponsors, OA Pharmaceuticals and Science Integra platform, which has been kind enough and gracious enough to be holding this whole webcasting from 4 to 9. And I will tell you the exact count, how many people have got registered, but till the time I joined, I think 1500 members had already registered and logged in. So I'm sure as we move on the whole day and in the evening, it is going to be much more better. I welcome Dr. Rajendra Sangpar, also my close friend who is being there. And with this, I would like to start with the program. Sana, can I have the first the slides of the members who are going to participate in this program? We have Dr. Prakash Trivedi, sir. He's going to join right now. He's in a meeting. He is going to join us later. He is one of the guests of honor. Can we move on to the next one? So these are the speakers which have been lined up, and we have exclusive moderators who are going to take charge of this session. They are going to directly interact with you, take your questions, and give this to the speakers, which are going to again give you those answers. So I don't want to be in between you all. I hand over the mic to my best friend and colleague, Dr. Mahesh Gupta, and I request him to please take over the first session. Thank you, Dr. Rishikesh. Thank you, Dr. Nandita Palshetkar, for giving your valuable time and inspiring and encouraging us. Thank you so much for being there. Dr. Mahesh Gupta has received Times of India Health Icon Award, Ahmedabad City 2018. He has a 50-bedded multi-specialty hospital at Ahmedabad. He's on the editorial board member in the World Journal of Anemia. We all know in 2013-14, he was the president of Ahmedabad Obstetric Gynec Society. And the most important thing is that he has developed and patented a wonderful COMOC MG operation, which is endorsed by RCOG. It is very different, but very helpful, especially when you do not have a super specialty or a tertiary center facility, and you save lives of women who are suffering from atonic PPH. So I hand over the mic to Dr. Mahesh Gupta, and please go ahead and start the session. Thank you so much.
Thank you, Niranjan. At the outset, I am thankful to you, and I feel honored and humble in the team where the Lakshmi and Saraswati combination like Nandita is there, and the Maharana Pratap kind of personality Narendra Malhotra is there, and from Bombay the Shivaji Maharaj kind of personality Rishikesh is there. So it's my privilege to be here and to moderate this session of endoscopy, which is nowadays a day-to-day in practice, because the many our infertile patients needs fertility correction surgeries. So this is a timely webinar, and in Corona time, it is our passion which do not stop us by teaching the people, and still people are also interested to learn the newer and newer things. And we have a galaxy of the speakers today who are really a master in subject and who are doing day-to-day work in endoscopy related to the infertility. So much registrations are there. So without wasting much time, I will be happy to start our session from the first speaker. So the science integra people, let us have our first speaker. Can they start?
We have a net issue here.
Okay.
We will be starting with the first speaker. I think we will start with Dr. Narendra Malhotra because Dr. Rajendra Sangpal sir is on his way.
He's
I'm
there.
on call. I'm
Yeah, he's here.
Acha, he's here. Okay.
Yeah. He must be sitting in his car, no?
Yes,
Okay.
I'm in the car. I was operating. Is my screen visible?
Yes, we can see your.
No. Your screen is not. You are visible. Your screen is not visible, Rajendra.
Yeah, your screen is not visible yet.
Now?
No.
Now?
Yeah.
Now?
There is some change, but still.
Now can you see my presentation?
Yeah.
Now?
Yeah, it is just. Yes, now we can see.
Santa Kumar is coming here. We'll all have you back. Without all of you, the Malhotras, the whole family of Malhotras, and Niranjan, Mahesh, Nadita, Rishma, Rohan, all of these people, and so many, Amaya, all of them, and all of you who are listening to us, you are welcome.
It's a recording. Recording started.
Recording replay हो रहा है.
No, it's recording started.
Thank you, Dr. Rishikesh Pai, for those comments. Dr. Nandita, I know
it is a replay. Niranjan.
Yeah, but I'm not doing anything.
Yeah.
There is a net issue. And
Yeah, Dr. Sangpal's slide is visible now. First slide.
Way back.
Yeah. Can I start?
Yes, please.
I thank you, Niranjan.
Thank you so much.
Thank you, science.
All of us, that how you can do science with travel, with education, with
The
training.
request to the Science Integra people is concentrate on the audio and video of Dr. Sampal.
And I think, madam, I want to add just 15 seconds. We are the only organizations where we as a gynecologist have different platforms. And every week
The virus. I cannot hear Rajendra at all.
No, I'm starting very quickly. I'm getting some. Okay, now. Thank you once again for being in this, by involvement in this particular CME. Thank you, Niranjan, and thank you all of you and Science Integra. You know, the topic which has been given to me is laparoscopic myomectomy and suturing. So, you know, laparoscopic myomectomy is nothing new for everybody, but there are some primary areas of concern when you are doing laparoscopic myomectomy. Whether you will be able to do adequate closure of myometrium, how much time will be involved when you are doing myomectomy, that's the operative time, integrity of the myometrium after doing laparoscopic myomectomy, and post-operative adhesion formation and safety of these women procedure in women planning pregnancy. And about the morcellation is a whole together different topic, but all of these are the areas, primary areas when you are doing laparoscopic myomectomy. Uh, the Whenever you are doing laparoscopic myomectomy, I would just like to give you a little guidelines about what is the patients when you choose. You must trust yourself or believe yourself whether your myomectomy procedure done laparoscopically is going to help the patient or not. I would say at the beginning of your laparoscopy career, you must not choose patients which are big fibroids, especially more than 8, 9 centimeters, patients who have more number of fibroids, 3, 4, 5. Irrespective of your skills, the amount of time which will be taken for surgery, it depends upon the size of the fibroid, the location of the fibroid, and the number of fibroids, and your operation theater setup. So everybody will reach to a period, or everybody will reach to a stage where they will be able to do difficult surgeries and give justice to your procedure and to the patient. See, the operative technique will have, the risk of hemorrhage is always there, and post-operative adhesions, and the bloodless enucleation of myoma is absolutely necessary, and the suturing is the important part of myomectomy. Myomectomy is the only procedure or where you require, good suturing skills. You can, even in hysterectomies, you may not have to suture laparoscopically. You can avoid suturing at all. Now, where do you should put your incision? And it has been very clear, and in the literature since 1999, the blood supply to the uterus is this way. The uterine ascends and sends the arcuate arteries at various levels. When you take a transverse incision, less number of blood vessels will be cut, and the amount of blood loss will be limited. What we learn from our during our residency, that single incision, anterior incision, and remove all the fibroids through one incision and a vertical incision. That was what we learned during our earlier days. But that may not be true. Now the literature is very clear. As I said, when you take a transverse incision on the uterus, your blood loss will be less because of the arcuate vessels, which they are transversely arranged or circularly arranged at a different level. Two is suturing of the transverse incision or an elliptical incision becomes more easy laparoscopically. We do take, the elliptical incision as far as laparoscopies, myomectomies are concerned, elliptical or a circular incision at the base of the fibroid. So by the time you, this was a posterior wall around 6 to 7 centimeter fibroid, which was subserous and intramural. When you take an incision like this is how the incision has been taken. Initially, we inject vasopressin. The vasopressin is available as 1 ml solution, that is equal to 20 units of vasopressin, and we inject into the subserosa or a pseudo capsule of the fibroid, and we taking due precaution and telling the anesthetist beforehand that you are injecting vasopressin into the fibroid. There are some adverse effects which you see very uncommonly, especially hypertension and sometimes, arrhythmias, but they are usually benign, and very, very rarely we have seen or heard of incidences where patients have landed up with cardiac arrest. So you should be taking care. When you take a circular incision at the base of the fibroid, you just keep cutting into the fibroid and just give a traction over the fibroid. You do not have to use any amount of energy source. I always believe everybody has their own way of doing laparoscopic surgery. So majority of the time, there is what you call the energy sources are being used. But if you search the literature and if you see, if you do use electrosurgery, there is more charring or more damage to the tissue. So that is going to cause, that will affect the subsequent healing. And the process of healing will give rise to a weakening of the scar if you use more amount of electrosurgery. So you have to be very balanced when you are using electrosurgery, especially in laparoscopic myomectomy. The scar may become weak subsequently. Majority of the patients who have had rupture of the uterus during pregnancy, they have found that the monopolar electrosurgery or electrosurgery was used while enucleation of the fibroid and the incision over the myometrium. So you so this is how we proceed with the myomectomy. So operative, that's what I said. Electrocoagulation must be used as sparingly as possible. The use of electrocoagulation may induce necrosis. Deficient suturing may result in uterine rupture. And apart from pedunculated myoma, rest of the myometrium, in these myomas, what you require is only a sharp scissor and a myoma and the vasopressin. So as far as possible, if you try not to use the electrocautery, the incision depends upon the location of the fibroid, the size of the fibroid. Usually, the incision is circular. By the time you take a circular incision, you will be able to do the majority of the fibroid is out, and you just require a little traction. Do not. We have always belief of the fibroid gets only blood supply at the base. That's not true. Fibroid gets blood supply from all over. It need not be necessary that you are cauterizing at the base. As far as suturing is concerned, whether there is a lot of controversy, I would say everybody, as I said, preference towards the suturing. If the myoma defect is too big, or if the myoma bed is too deep, then multi-layer suturing is advocate. If the myoma bed is sufficiently can be managed with single layer suturing, one must do a single layer suturing. The end result of your suturing does not depend upon the number of layers, remember. In fact, if you have a deeper defect and if you keep suturing in multi-layers, you will provide or you will have more number of sinuses that will have a hematomas and subsequent fibrosis and weakening of the scar. So number of sutures does not mean that's a safe myomectomy. In fact, when you do a laparoscopic suturing, a correct approximation of the defect is extremely important as far as the end result in terms of the strength of the scar is concerned and subsequent fibrosis. Now, this is how we do laparoscopic suturing from the right side. I always operate from the right side. The suturing from the right side, 2 ports, 2 centimeter medial to the anterior superior iliac spine, and the another port which has been placed just lateral to the umbilicus, 4 fingers away from the umbilicus in mid-clavicular line on the right side. And the suturing exactly mimics the laparotomy suturing as we do for cesarean sections, abdominal hysterectomies, and myomectomies, or laparotomy myomectomy. So I believe suturing from the right side is comparatively easy as compared to suturing from the left side. But I wouldn't advocate for any person to just change over the side, because it becomes very difficult as far as the right side suturing is concerned, or change of position of surgeon preference is concerned. So as I said, the suturing and the incision all depends upon size, location of the myoma, and depth of the uterine defect. That's important. As I mentioned, suturing from the unilateral side is always easy, and which I already told you. So, 2 things. One is, as far as possible, avoid elective surgery. In fact, when you give a vasopressin, it achieves a temporary effect of hemostasis for a nearly 40 minutes or 45 minutes, which is sufficient to remove the fibroid from the uterus. So, if you have used vasopressin, why should you use electrosurgery? There is no need of using any electrosurgery. Just a simple scissor is enough to cut the myometrium or the pseudocapsule over the fibroid. Giving a traction and the right incision makes the enucleation of fibroid very efficient. There is no need of assistance which is required. Your vaginal assistant is supposed to be the best assistant in laparoscopy. Turns and rotates the uterus as required. Suturing, and third is suturing from the right side really helps. As far as multiple or single layer suturing, as I said, when the uterine cavity is opened, or when the myomectomy defect is very deep with lot of redundant myometrium, then only you must do the suturing in multi-layer. So this was a patient where, it was a deep myoma, and then the enucleation was done in similar manner like the circular incision. Why do we take circular incision? People always criticize me many of the times. We are removing lot of redundant myometrium, but remember, when we do laparotomy myomectomies and when we excise a large amount of myoma, and when there is large amount of redundant myometrium is remaining, we always cut the myometrium and refashion the edges and do suturing. So if you do that in the beginning part of the myomectomy, taking the incision at the base of the myoma, then enucleation becomes easy. Your surgery becomes completely bloodless, and the suturing also becomes easy. In one layer, you can do laparoscopic suturing and close the defect. So that's how this was a myoma which was deep enough. Correct reapproximation depends upon the technique of full thickness, evenly spaced suture placements, thus avoiding hematoma formation. If my time is over, just let me know. When you see the literature, the single layer closure of uterine defect, it's an interesting study. Even Dr. P.G. Paul is one of the papers he has described that there are a number of patients, say almost more than almost nearly 900 patients were studied, where pregnancy rates were in the range of 30 to 60%, and the rupture of the uterus, when you suture the uterine defect with a single layer, the rupture rate was 0. So it's interesting that you should not believe that only if you do multi-layer suturing, then only the scar is going to be effective or the subsequent results are effective. That's not, I feel, not true. So it always depends upon how you suture and approximate. So as far as suturing with barbed sutures is really a good innovation, and barbed sutures are really a good innovation, and that reduces the time required for knotting. But always, barbed sutures, they have a fixed length, plus they are little stiff. That also makes them little, that's a disadvantage. The suturing becomes little cumbersome when you are using. But everybody, as I said, their own choice. One can use barbed sutures. I don't do barbed sutures because I'm used to so much with the Vicryl, so I don't do barbed suturing. Hello? Hello?
Yeah, you are audible.
I'm audible, no? Yeah, okay.
Yeah, but there is some problem with screen. Yeah.
Now, okay. So, how much time is the waiting period? There is nothing like a fixed waiting period till you commence the ovulation induction or for achieving pregnancy. But usually 4 to 6 months is the time period. It's an arbitrary time limit when you do myomectomy and ask the patient to become pregnant. Less than 3 months, if the patient becomes pregnant, especially for deeper fibroids, there is possibility of the scar rupture. It can happen because of the ineffective scar formation. So that's important. As far as the multiple fibroids are concerned, when you are doing multiple fibroids, as I said, myomectomy is the only procedure which tests really your skills. Now, a larger fibroids, if you say, I have seen WhatsApp messages, I have seen the videos which come up, and people have tried and removed like number of kgs of fibroids. But as I said in the beginning, please don't try to do it. I have seen people operating from morning to evening for doing one case and having removed fibroid of say kgs, but that's not correct for the given patient. If you can have a bigger fibroid is going to take its own time. Multiple large fibroids, 5 centimeters, 7 centimeters, 6 centimeters, 8 centimeters together is going to test your skill and going to take a lot of time. So it would be, I would at the end, I would give message, you judge your judgment that my myomectomy is going to give, a laparoscopic myomectomy is going to be helpful for this patient in terms of avoiding complications and giving a good result. So if you feel that you can able to do this myomectomy within a span of 2 or 3 hours, that should be your end limit. And the complications of laparoscopy which have not been reported, especially in our scenario, like especially hypothermia, CO2 embolism, deep vein thrombosis, pulmonary embolism, and other things, infection, post-operative infections, and having peritonitis, they've not been reported on a regular basis because the amount of time which is required for surgery is tremendous. So have your own judgment. Yes, I am going to finish this surgery in next 2 to 3 hours, and that way I'm going to give a good as well as outcome to this particular case. So single fibroids, upper limit should be 7, 8, 9 centimeters for a beginners, and multiple fibroids, maybe total length amount of the size of the fibroid should not be 3 or 4 fibroids together should not be more than 15 or 16 centimeters together, 4 centimeters, 3 centimeters. Otherwise, I have seen people have removed 50 fibroid, 60 fibroid, but that's going to take time. Patient will bleed. That's important. Suturing single or double layer depending upon the depth of the myoma, and of course, they try and avoid the electrosurgery whenever you are using vasopressin. So thank you very much for patient hearing, and thank you Niranjan once again, and thank you my friends.
Thank you, Dr. Rajendra, for a nice elaboration of the myomectomy, laparoscopic myomectomy. So if there is any question, they can put in on the chat box, so I can read out the question from chat box. So, Dr. Sampal, have you ever come across a case of scar of intramyometrium, scar of myomectomy, and pregnancy within the scar of myomectomy?
Fortunately not, but I have heard of cases,
Yes.
especially after myomectomy, within the scar, the pregnancy has happened. It just behaves like a scar, cesarean scar. So pregnancy is still possible in the scar, and we have to treat it as like a scar ectopic pregnancy.
Yeah, in cesarean scar, pregnancy is sac in the endometrial cavity, but it is protruding towards the scar or within the scar. But I had seen a case where the whole pregnancy has grown up in the scar of the myometrium. So the uterus and endometrium was one side, and pregnancy was growing in the posterior myomectomy scar, and that was treated same as a cesarean scar ectopic. But I had come across one case of intramyometrial scar pregnancy.
That's interesting.
Yes.
Yeah.
So any more questions? So now can we go to our another esteemed speaker? Our next yes, Dr. Narendra Malhotra. I have already told your stature in Foxy.
I am not carrying Talwar and Balas. Only a TVS and a scope in my hand.
No, there are only 2 luminaries in India before independence. So that were Maharana Pratap and Shivaji Maharaj. So it was in context to that. Anyway, now it's web is yours, Dr. Narendra Malhotra.
Share screen.
Welcome, sir. Thank you for coming today. I know you are very busy with a lot of meetings which are happening. Thank you, Rajendra, for a wonderful lecture. Thank you so much, Rajendra. In spite of your busy schedule and your commitments to the family, you have given your valuable time. And I want to tell you, we have got more than 1,500 members which have live and logged in. And I've just heard Dr. Narendra Malhotra, they are going to hear now, and Rajendra Sangpar, who had just concluded a wonderful lecture on laparoscopic suturing and myomectomy. Welcome, sir. Thank you, Mahesh.
Thank you, Niranjan.
So, a very good afternoon to all of you. I've been asked to talk on what ultrasound can do in infertility, past, present, and future. And ultrasound for infertility was first used in the 1980s, and was Professor Kratrichel who devised the first TVS probe. And Jaideep and me were very, very fortunate to have worked under him in Vienna when the TVS probe was first devised. And then it was our own Indian from Pune, but settled in London, who first told Patrick Steptoe that why can't we take out the eggs through the vagina? Why do you do it laparoscopically? So 1990, again, we were very fortunate to be with Rajat and Patrick Steptoe when this happened. 1992 was the first TVS Congress in Chicago, which again, I was invited, and Jaideep was also invited to talk on our Indian experiences. So we've been into ultrasound since a very, very long time. And then we had color Doppler with Kurjak et al. So this was the first TVS probe. It was a fixed probe, and the patient had to sit on it. And this was the kind of first type of machines, the portable machines. I'm not talking about the iron donor big, huge scanners, but these are the ones which were used in the far past. Now we have to remember that when you do a transabdominal scan, you need a full bladder, and the sound wave goes in and then sees it. When you use a TVS, you are right next to the cervix, and the sound waves goes this way. So to both, a little bit of orientation was required. And again, we remember with Mahesh, we have done the 6 weeks Ahmedabad orientation courses of ultrasound, and they were great fun. Every Sunday we used to go there and have lectures on Sundays and practical by Dr. Mahesh at the local area. So transabdominal and transvaginal both are needed in infertility. Now, a lot of people say it's very difficult to orient. Well, you drive a car, you're looking ahead, and you're changing the gear with your left hand, and you are seeing the car. So it's like pushing and pulling and turning, and then orienting the image by right angle. So we have to prepare the probe and with a lot of jelly, and then you have to orient to the pelvis. So the patient is lying down like this, and the image is coming like this. So ideally, the image also should come like that. But with Rajat Goswami, the image used to come like that. The Europeans make the image upside down. So whatever it is, what your brain can do it like that. Now that was a little bit of the past what happened in ultrasound. The present, which is still going on, is that now we're using routinely color Doppler, we're using extensively 3D, 4D, and we are also using high definition 3D, which is Shillut image. And we are using a lot of contrast. And there's a lot of software which has come and infertility. So for infertility clinics, ultrasound has become mandatory. Cannot be. What you can do with it, from vagina to ART procedures, everything can be assessed, and a lot of things can be treated by ultrasound. Christian Doppler told us the Doppler effect. We wanted to know how much blood is going to the organ. So it's the RBCs which go, and when the sound strikes the RBC, depending on the speed of the RBC, reflects back, and we get a frequency shift, and we get a wave pattern which tells us how much blood is going in systole and how much blood is going in diastole. And then the machine calculates. Now my calculation is that every muscular artery, systole and diastole, is 30% in height. So approximately the resistance would be 0.7 and the pulsatility would be around 2 or 3. That pulsatility is how the wave. So if the artery is rigid and does not expand, you get a wave which is higher, pulsatile, and the lesser diastolic. So the resistance increases to 0.8, 0.9, or even 1 maximum. If the vessel is dilated for physiological reason, or for inflammation, or for cancer, the artery dilates and it allows more than 30% blood. So just remember, looking at the wave will tell you a lot about it. Otherwise, it's a change of frequency. Now look at this wave, and the systole and the diastole is about 30%. So it's a normal uterine artery wave. The color Doppler will identify how much blood is going by looking at the systole and the diastole of the wave. And you can calculate the RI and the PI, ST ratio, peak systolic velocity. Look at this wave pattern. The diastolic flow is almost 50%. So this is in the uterine artery in pregnancy or in the umbilical artery, where a lot of blood is needed. And this happens naturally in physiological ways. Now let's go one by one. We'll see what ultrasound can do in present. You can evaluate the cervix for size, shape, cervical mucus, Nabothian cyst, everything. You can evaluate the uterus for uterine musculature, cavity, endometrium, fibroids, adenomyosis, color flow, uterine scoring system for reproduction. Especially if there are multiple fibroids and how they have to be removed, what the surgeon needs. This is what the surgeon needs, whether hysteroscopy is possible or laparoscopy. Adenomyosis, the classical salt and pepper appearance, and when we put color flow and power Doppler, you see that the spiral artery flow in those areas. So that tells you it is adenomyosis there. Evaluation of the cavity, we can do it by various methods. TVS today, like that, or by HSG, which we usually don't do now. TVS with contrast, that is saline, 3D with or without contrast, and hysteroscopy. Hysteroscopy was the gold standard, but today with high imaging, high definition imaging and Shillute imaging, we have. Why we want to know the cavity? Because this American Society of Reproduction 1 to 8, we want to know which type of uterus it is, or we want to classify it according to the Eschre ESG on the UCV anomaly which we are there. So ESG classification has become very easy when you do 3D. Why? Because you can see the coronal view. And with the coronal view, you can tell whether it is U0 or U4. And similarly with the cervix. So that's all the duplication anomalies. So volume imaging has become like a virtual hysteroscopy. Look at this uterus specimen. It's a cut specimen. That's a cavity. And I've just superimposed it with a hysteroscopic picture of the same. So hysteroscopic picture is absolutely the same. So that is what the 3D picture. So 3D has become now almost like a gold standard. Why? Because again, the coronal plane, the outer contour, the inner contour, the myometrium in between all the sides, the uterine length, the cavity breadth, the cornua, everything can be seen. And we can classify if the cavity is divided into a partial septum or a complete septum. We don't no longer use the word arcuate. So it's a septate uterus, whether it's partial or whether it is complete. And whether you're going to cut it or not, the arcuate which was there previously was said, when you draw a line between the two cornua, less than 0.5 millimeters, half a centimeter, and more than 1 centimeter, then this septum needs to be cut before anything required. And then see, this is the new imaging. So this is the Shillute imaging where you throw extra light into that area and you get the contour and everything divided. So bicornuate uterus, partial septate, complete septum, and all which need to be evaluated. Look at this, how beautifully the 3D can do it. You see the 3 coronal views and you see the 3D. So 3-dimensional can tell you whether the uterus is normal, arcuate, septate, or bicornuate. And the newer probes in the machines give you pictures as good as this, which are actually as if you're looking at the uterus. And they give you pictures as good as this when you put in saline, and that's a degenerated fibroid, and it is jutting into the cavity, but it is also jutting on the serosa. So to remove this big fibroid, laparoscopic would be better than a hysteroscopy, or we do 2 sittings of hysteroscopy. Cut it here, remove as much as we can, then let it after 2-3 months come into the cavity and remove in second stage. Now when I put fluid in, then I put the Omni line. And when I put the Omni line, I can get the cavity so beautifully seen. Partial small polyps or the Asherman, everything can be seen. We also know that the endometrium has good correlation with the estrogen, and it is very, very important to evaluate the endometrial-myometrial junction. So the endometrial-myometrial junction is a halo all around the 3 line, or what we call as 5 line. Now if this halo is not there and is broken, then that is a sign of adenomyosis. That means the endometrium is broken from here and going into the endometrium. And this can be better seen by 3D. You look at the endometrium which is going there. Look at the stria of endometrium which is broken on the fundus and is going into the fundus and forming adenomyosis area there. What about color? Yes, we can put a full color and see the whole arcuate artery width. You study the uterine artery receptivity by looking at the pulsatility index and the resistance. If the pulsatility is more than 3 and the resistance is more than 8, then it is very unlikely that any pregnancy will occur. So this can be done in the dummy evaluation cycle or even before embryo transfer. And you can do the thickness and the characteristic of the endometrium, and we take a cutoff of 6 or 7. We in our center take 7, but even pregnancies have been reported with 6. And then we see the pattern. So at the time of embryo transfer, the pattern should be secretory, and at the time of ovum pickup, the pattern should be getting to secretory, 3-layer with all with the thickness being there. And then we look at the spiral artery flow. So spiral artery flow will also tell us how it is. And how do we calculate, quantify the spiral artery flow? If the spiral artery is seen only outside zone 1, if they're touching the outer layer, zone 2, they're going inside zone 3 and zone 4. For successful pregnancy, you should have zone 3, zone 4 blood flows. This can also be seen by power Doppler, 3D power Doppler. So you've got a 3D picture and you put the power Doppler in and you can see only the vasculature without the grayscale. And again, you can quantify VFI, VI, RI. So you can get values. So there are values for 3D also. Now the pregnancy rates are much better if you get the zone 3. And zone 3s are divided like this. So zone table, zone 1, 2, 3, 4. And that's how we divide the zones. And see the vascularization. Now this was on day 8, 9, the spiral artery flow on a good stimulated cycle, day 10 and day 14 on the day of implantation. And if progress is happening like this, we are very, very happy that this is a very receptive endometrium. This all can be scored theoretically as Applebaum scoring or uterine biophysical profile or uterine scoring system for reproduction, USSR, based on 7 parameters with a maximum score of 21. But look at the waves. Uterine artery without diastolic flow would be on day 1 or day 2. Day 3, day 4, estrogen, little bit of more blood flow comes. And when it becomes 30% of systole, that means the estrogen is coming and it's a normal uterine artery. And if at the time of ovulation, this will go to about 40% or 35%. What about tubes? Yes, tubes can be evaluated today by ultrasound in the present. And we do it by putting in a Foley's, as you can see here, and then injecting saline and looking at the bruit. So if you see a bruit, color bruit coming in the color box, which covers the whole of the screen, then you say this tube is patent. So you can tell which side of patency is there. And then after that, we deflate the bulb and do a sonohysterography. So it's a complete examination like we do hysteroscopy and laparoscopy. Here is sonohysterography and sonosalpingography. So patent tube, blocked tube, no fluid back. So it was blocked, confirm that. But this shows that both tubes are patent. This can also be done by a normal feeding tube and you inject saline while scanning the TVS probe. So any uterine pathology can be very easily picked up. Can also be done by contrast media, HycoC with EcoVist. And with HycoC and EcoVist and 3D, you look at the spill, look at the hydrosalpinx, look at the pyosalpinx, hydrosalpinx, in cogwheel appearance, everything. And you can get pictures as good as this when the color flow, when the fluid flows through the tubes and you've got the power Doppler on. And then you erase all the gray and you get the beautiful uterus biconduit and for a deep septate with the fimbrial end also. And again with color power Doppler like this. And then we can remove all that. If it was a hydrosalpinx, we can see hydrosalpinx cells. Lastly, the ovarian flows. Day 2 evaluation of the ovaries become very important. Then we measure the follicles in infertility. We look at the cumulus and the double contour, which tells us that it is impending ovulation. And then we see infolding in the cumulus, again impending ovulation. And this follicle will give you an M2 oocyte. So that we can. If there are many, then we do an automatic calculation. Sono AVC. So each follicle, according to the volume, is given a color. And you get a report according to the volume. There are still no parameters to say that this volume follicle will rupture, but you get a report like this. Red, blue, yellow, depending on the volume. And this, the correlation on getting a pre-HCG timing according to this is being done. This is how we see the infolding of the follicular wall by this thing. We also can study the uterine ovarian vessel Doppler and see that the when the follicle is about to rupture, the blood flow increases. Then you do a lot of interventional procedures these days with ultrasound. So like this, the follicle pickup, follicle aspiration from the follicle, and cyst punctures. Cyst punctures. Pre this thing we have done a plain cyst which is not going, so we remove, aspirate it and inject ascarol in it, and 80% time it does not recur. Then ectopic pregnancies, you can aspirate the ectopic by 17 gauge needle, or inject KCl and potassium chloride, and if it is live, then potassium chloride and methotrexate. Otherwise, we can also inject sperms in the pouch of Douglas and monitor all the side effects today. And of course, we do if there is multiple pregnancy, we do the embryo reduction by I prefer transvaginal early embryo reduction. And there is a good debate going on whether it should be early or should be after the 11-week scan. But early, the dead weight is less, and it's an easier procedure, and the continuation pregnancy rates in our study, which is now published, is very good. Lastly, a couple of slides on what is coming. So what is coming in ultrasound is self-monitoring home device. Patient can take home the transducer, do the follicle monitoring on our own. Miniaturization, the ultrasound will come on your phone. Software improvement, special 3D orientation, completely automatic artificial intelligence evaluates the whole pelvis for you. Pelvic reconstruction and the probes on your finger. So once you're doing a PV, you can do the imaging. So marrying palpation with imaging. But it was Ian Donald who, when first saw the BPD and ovarian cyst in his daughters, he said, "This is it. We cannot do anything more. We have gone into the Pandora's box." Well, he was right. We have not improved in the ultrasound technology at all. It's the same piezoelectric crystals. But Ian Donald never saw that computers will be coming in. So it's the computer technology and the analysis of those waves which has changed the whole scenario. So ultrasound from big machines are now going to be this small, pocket wireless ultrasounds. The sonoscope is already available. I know in India we'll have problems with PCPNDT, and it fits into a small box, and the whole probe can be just put on it, and you can watch it on your TV screen. So this is what is going to happen. You can connect it by wireless to a normal TV, to a normal monitor, to your phone, to anything. Only that you just have to buy this. And it's very easily available. It's wireless ultrasound probe. And it can also fit on it. And this TV wireless probes also are available now. And this can, you just take the TV probe and the picture gets stored wherever you want it. Then patient-centered ART, because patients are very scared to come to the clinics. And injections. So self-operated endovaginal telemonitoring is going to be there. And this is a probe which is given to the patient, and the patient takes it home, connects to the internet on her PC, and connects by the software, and immediately the image is transmitted to the clinic, and they tell her, move the probe to the right, move the probe to the left, and you get an ovary, and the machine automatically measures all the follicle. So 10 years from now, I can imagine speaking with the young ultrasound specialist about the old days. I will tell them there was portable ultrasound, because I don't know what is coming in 10 years hence from now. So, but in the words of Professor Sim Kuriak, ultrasound was the past, ultrasound is the present, and ultrasound will always remain the future. Whatever technology comes, whatever molecular genetics comes, whatever chromosomal anomalies comes, it will be ultrasound in infertility and in especially in pregnancy, which will always remain. Only the computer technology will improve, and we'll get much better images. So to practice infertility without TVS is like walking into the dark without a torch. You're going to fall many times. You might a couple of times reach the goal. And turn on your color to improve your image, and use the third and now the fourth dimension. And for best results, I would urge all the gynecologists to do it yourself, and do not depend on your radiologist colleague or your radiologist husband also. Do it yourself. Thank you very much for inviting me here and sharing this topic on what was and what is going to be in ultrasound.
Thank you, Dr. Narendra Malhotra. It's always a pleasure to see you and to watch you on ultrasound platform. I remember in 1996, I had organized an ultrasound workshop in Ahmedabad, and you all were invited. In Gujarat, it was our tradition that gynec and obstetric ultrasound should be done by a gynecologist, not by a radiologist. So since 1992, we were doing this kind of workshops, maybe a live workshops and the lectures. So that's why today in Gujarat, many gynecologists has adopted a practice of ultrasound as a fetal medicine specialist. So here the obstetrics and gynec ultrasound is more done by the gynecologist than the radiologist. And that was our motto, if you remember, Narendra, from 1996. So again, thank you very much, and thank you, Niranjan, for making me a part of this wonderful forum. And I wish all the best to you for your future endeavor in IIG. Thank you, Niranjan. Goodbye to everyone. Thank you.
Thank you. Thank you, Dr. Mahesh Bhai. It was a pleasure for you to join from Gujarat. Now, I would also like to thank Dr. Narendra Malhotra, sir. Sir, you have explained so lucidly. There are no questions for you. And it is amazing that you are...
Questions will come on my phone. I'll get about 100 questions today. Every day it happens like that.
Sir, you
anyway, are welcome. Everyone is welcome.
You have explained it so lucidly, and I appreciate the efforts which you went and through the history, what you did along with Dr. Goswami, and the efforts which you have done. So we are very proud of you that you have been doing Iron Donald courses for I think more than a decade now, and it is such a popular program which has been going not only in India, but I think it has gone beyond boundaries to SAR
163 countries, 163 countries.
Yes. So it's amazing, sir, the amount of enthusiasm and energy and experience which you have, I don't think anyone can surpass with so much abilities and the creativity which you have. Sir, you have given your valuable time in spite of your efforts and your meetings. Thank you so much for giving us that opportunity. And there are more than 1,600 members now logged in. They just saw those and they're in awestruck with that. Thank you so much. Thank you.
Thank you. Thank you very much.
Now I request my friend and colleague, Dr. Basab Mukherjee, to please come and moderate this session. You can see the dedication that he's driving a car and he is still on with us. And yesterday, day before yesterday, it happened with Dr. Basab, and today day before yesterday, it happened with Dr. Bhaskar, and today it's with Basab Mukherjee from Kolkata. So I welcome Dr. Basab Mukherjee. He is done his medical schooling from CMC Vellore. He's the FIGO coordinator, South Asia Safe Abortion Committee, clinical examiner for RCOG examinations in India. He is also the Vice President-elect 2021-22 FOXY, Organizing Secretary of AICOG 22. He is currently the Secretary of Bengal Obstetric and Gynec Society. And we all know the wonderful award he has received at AOFOP 2011 at Taipei. Without wasting much time, I hand over the mic to Dr. Basab to introduce the next two speakers.
Thank you, Niranjan. Thank you. It's always a pleasure to be here, and it's my pleasure to introduce Dr. Bhaskar Pal. He's a senior gynecologist at Apollo Gleneagles Hospital, Kolkata. He's an honorary General Secretary IAGE 2019-20, the chair of RCOG India, not East. He's the All India chair now. He's elected, and he's the president-elect of the Bengal Obstetrics and Gynecological Society, was the vice president of FOXY in 2017, and it's an Excel Masters, and we are all ears. Dr. Bhaskar Pal, the stage is yours, and I think you can start screen sharing. The printed time minutes, but I think we are here being a little flexible. So please take your time. Thank you.
Thank you, Bashuk, for the kind introduction. And thank you, my dear friend and my classmate, Niranjan, for inviting me to this wonderful program. And Dr. Narendra Malhotra spoke wonderfully on ultrasound in infertility. And from then onwards, I am going on to an approach to an adnexal mass. Now, whenever we are there, when we face an adnexal mass, what is the differential diagnosis? It might be an inflammatory tubo-ovarian mass. There could be a cyst accident like hemorrhage or torsion. It could be a benign lesion on one hand, hydrosalpinx or endometrioma or a dermoid, or it could be a borderline tumor, or it could even be epithelial or
It has been sent
non-epithelial
to your
cancer.
own email. I will send again.
Now, why do we need evaluation? We need an evaluation to decide whether this requires an operative management or whether we can manage this conservatively, either with expected management or medical management. And if we are planning a surgical procedure, do we need to do a lap? Can we do a laparoscopy or do we need a laparotomy? If we are planning to do a laparoscopy, the evaluation will lead us to plan the exact procedure, and that is very important, especially when we are considering somebody who desires fertility in the near or distant future. If we decide we are going to do a laparotomy, again, the assessment lets us decide whether we go with a phalansteal incision or we need a midline vertical incision. And again, whether we can helps us plan the exact procedure and also the need to have a gynae-oncologist on standby. Now, there are three parts of assessment of an adnexal mass, and you cannot make a correct assessment without the three arms of that. And the first arm is a history of an examination. And alas, today with technology advancing, many a times we tend to pay less attention to history and examination. The second arm is, of course, imaging, and the third arm is tumor markers. In the history, what is important is the age, the family status, family history, whether there's any history of pain or pressure effects, history of weight loss, vague GI symptoms. Somebody presents with a large adnexal mass with weight loss and vague GI symptoms should send alarm bells ringing, because many ovarian cancers present with some vague symptoms like those. Presence of vaginal bleeding, which we are more likely to see in a hormone secreting ovarian tumor. Also, if there is any comorbidity. In the examination, we need to assess in the very traditional way, we need to assess the size of the mass, the mobility of the mass, the regularity, the consistency, the presence of lymph nodes, especially supraclavicular. If we find bilateral solid ovarian tumors, then we need to do a breast examination because we're looking for primary. And we also need to assess the general health, because the general health and the comorbidity are also a very useful guide while we are planning the exact procedure. Now, what would be the investigations? It could be as less as a sonography and one or two tumor markers. We will also discuss when we need to do a CT or an MRI. Now, usually transvaginal sonography would be the best. Ultrasound is a good initial test because it has a high negative predictive value for cystic lesions. CT is better for diagnosing pleural effusion, for assessing lymph nodes, anything else like omental thickening or omental mass, omental deposits. The advantage of CT is that it is less operator dependent, more easily available. And for adnexal masses, CT is usually better than the MRI if we have to do only one. The advantage of MRI is that it can distinguish blood and fat as contents, which is important, especially when we are in doubt whether it is a dermoid or whether it is an endometrioma. What happens to tumor markers? The most commonly performed tumor marker is a CA125, but please remember that it is non-specific. Even in terms of ovarian cancer, it rises only in around 50% of early ovarian cancers. It is raised in various conditions like endometriosis, adenomyosis, fibroid, PID, and tuberculosis. And we have seen CA125s in several thousands in endometriosis and tuberculosis. If it is over 200, we need to view with suspicion. But in postmenopausal women, any value above 35 should be viewed with suspicion. Sometimes rising titers are suspicious of malignancy. If we are in doubt and if we are repeating the CA125, and after 3 months we find the CA125 is actually gone down, it is very unlikely that we are dealing with a malignancy. What is ROMA? It is a risk of malignancy algorithm, and what it does is combine CA125, HE4, and menopausal status. Studies show that it actually does not improve sensitivity and specificity, and if you are faced with a mass which you are worried about whether it is an endometrioma or dermoid, then applying the Roma is not really helpful. Now, HE4 is one which is very useful to be added because, as we said, CA125 is non-specific and it is raised in many other conditions. And if the CA125 is high, then it is addition of HE4 which will actually help us in saying that whether this is from the marker is raised because we are suspecting an epithelial ovarian cancer or it is not. The others one which are done often is a carcinoembryonic antigen and is an LDH. The NICE guideline says that under 40 years, you should do a CA125, AFP, and beta HCG. The RCOG BSG joint guideline says that under 40 years, you should do a CA125, AFP, beta HCG, and an LDH. CA99 is frequently raised in mucinous tumors. And if the patient is menopausal, then we will do possibly, depending on the nature of the mass, a whole lot of tumor markers more. But in terms of sensitivity and specificity, HE4 plus CA125 combination is better than HE4 alone, and HE4 itself is better than CA125. Now, we all have heard of risk of malignancy index, and the reason I have brought it up is to criticize the usage of risk of malignancy index in premenopausal women or in young women. The RMI looks at three different issues. One is the menopausal status, one is the CA125 value, and one the ultrasound features. And the ultrasound features which it looks at is a multilocular, a tumor, solid areas, bilaterality, ascites, and the presence of metastasis. And it will give 1 point to each of these features. So how is the RMI calculated? There is RMI 1, which is ultrasound score into menopausal status into CA125, and you give an ultrasound score of 0 if the score is 0, and you give an ultrasound score from 1 to 3 if the score is 1, you give 1. If the ultrasound score is 3, then you give a score of ultrasound score is 2, 3, 4, or 5, you give the ultrasound score as 3. So essentially, let us assume that somebody who's got a bilateral tumor, bilateral multilocular endometrioma. So the ultrasound score will end up to be 3. If she's premenopausal, the premenopausal status, it is 1. And multiply that with a CA125, and let's assume that the CA125 is, say, 80. So you get an RMI feature which is 240 in a situation which looks like a typical endometrioma without any solid areas. For postmenopausal status in RMI 1, you give 3 points. Postmenopausal is defined by somebody who's not had period for more than 1 year, or in a woman who's over the age of 50 who's had a hysterectomy. Some people use an RMI 2, and in RMI 2, you give a score of 4 for postmenopausal. The SOGC uses RMI 2, and most of the people use 200 or 250 as a cutoff for RMI. As I said in the previous slide, that SOGC uses 200 when you should refer it to a cancer center, whereas the RCOG says that if the RMI is less than 25, then the risk of cancer is less than 3%. If it is between 25 to 250, the risk of cancer is 20%, and if there's more than 250, the risk of cancer is 75%. The point that I want to make is that RMI should be applied only when you are suspicious whether the tumor is likely benign or likely malignant, or it is suspicious. If it is a likely benign, then the usage of RMI would completely be misleading. And as I said, anybody with a raised CA125 level, which is even less than 150 or even 200, will end up going to a cancer center. So it is frequently inaccurate in women who are premenopausal, and that is why people who are doing a sonography on women with adnexal masses must be aware of the International Ovarian Tumor Assessment ultrasound rules. The IOTA group ultrasound rules are the B rules or the benign rules, and the M rules or the malignant rules. What are the benign rules? Unilocular cysts. If there is a solid component, but the largest solid component is less than 7 millimeter, it is still a benign rule, which the RMI doesn't recognize. Presence of acoustic shadowing, again, is a benign rule. No blood flow is a benign rule. Again, the RMI that doesn't look at the blood flow. And even if it's a multilocular tumor, as long as it is a smooth multilocular tumor with the largest locule diameter of less than 10 centimeter, it is actually a benign feature. What are the M rules or the malignant rules? Irregular solid tumor, ascites, at least 4 papillary structures, irregular multilocular solid tumor with the largest locule diameter more than 10 centimeters and a very strong blood flow. So if you have one or more B features without any M features, it is likely benign. And there is no point subjecting these women either to an RMI or to a Roma. When there are one or more M features without any B features, it is likely malignant. That is when we need to add a battery of tumor markers. That is when we need to add further imaging like a CT scan plus minus an MRI. If there is a presence of both benign and malignant features, then it is inconclusive, and then again we need further imaging and usage of tumor markers. The IOTA group simple USG rules has a high sensitivity and specificity, high likelihood ratio. Moving on from this, what they have devised is the ADNEX model, which adds the demography and the markers. Now, what does the ACOG says? That any premenopausal women with a pelvic mass should be referred to a gynae-oncologist if any of the following is there, which is CA125 is more than 200, if there is ascites, and if there is evidence of metastasis, which is abdominal or distant, or a first degree relative with breast or ovarian cancer. In our country, if we have to send all women with CA125 or more than 200, or all women with an RMI of more than 200 to a gynae-oncologist or a cancer center, most of these women will have to wait for years to get treated because we, in terms of resources, we are not that resourceful. The ADNEX model is the assessment of different neoplasias in the adnexa. It is developed by the IOTA. It incorporates the simple ultrasound rules and follows a logistic regression model where you put the patient's age, put the tumor markers, and it gives you a more accurate prediction from their website. So based on that, you can manage women with a conservative, with a follow-up ultrasound. It is a simple cyst, unilocular cyst, which is less than 5 centimeters with a normal CA125. If it's a small unilocular cyst, which looks more like a functional cyst, many a times you don't even need to do a CA125 in a young girl. For a low or moderate risk, you do a laparoscopy and you do an ovarian cystectomy or an oophorectomy depending on age and the patient preference. If you are unsure of what kind of mass it is always better to retrieve the in bag, avoid spillage, and frozen section if the facilities are available. And in high risk patients, which is suspicious of cancer, should be managed in conjunction with a gynae-oncologist. Now, more important is in adolescents and young adults is whenever we are faced with an adnexal mass, the questions that we need to answer is how urgent it is to treat. Is it that urgent that we have to take her as an emergency within the next few hours, or do we have time to at least wait for some tests like tumor markers or if necessary a CT scan? Do we go for laparoscopy or laparotomy? Not only laparoscopy is more cosmetic, but also laparoscopy will ensure quicker return to activities, and laparoscopy ensures that there are less additions in the future. Also, do we need to involve a gynae-oncologist? I will just end with a few examples of adnexal masses in young women. And this is an 11-year-old girl who had her menarche 14 days back with a lower abdominal pain, which started 7 days after menarche with nausea, vomiting. An ultrasound shows the right adnexal complex mass behind the uterus. The CECT was the same. The tumor markers were normal. Whenever somebody presents like this, whatever in a young adult who presents with adnexal complex mass, one of the first diagnoses that you have in mind is whether it is a Mullerian anomaly, whether it is a non-communicating horn with blood accumulating in that non-communicating horn. And when you put in a laparoscope, that might mimic very much like an endometriosis, but those endometriosis would not need to be excised. If you can restore the communication and leave it, drain it, then usually the endometriosis is reversible. The second thing that you need to keep in mind in these young women is whether the possibility of torsion. And we went in with a open mind, thinking that this could be an Mullerian anomaly, but what we found is a tubal torsion. Sometimes you'll find a tubal torsion. Tubal torsion is not that rare. We find once every 2 to 3 years. And please remember that when you see a torsion presenting as an acute situation, usually what you will find is that the torsion is of 2 or 3 twists that the patient would have had. And what happens is that we all knew, and we've been talking about that for a long time. And recently this year, it has been published in the British Journal that all young women presenting with a torsion, you should detort it and you should leave it alone. You should not remove the cyst, even if it looks necrotic to you, because in more than 90% of cases, it will resume its blood supply and it will actually get better. However, it is important to counsel that in a small number of cases, if it is necrotic, then the pain might not settle and you might need to re-laparoscope her in 48 to 72 hours if she's not well and remove the mass. But in young women who are desirous of fertility, is always better to what you to do it to preserve the adnexa and then take it from there. Now, this is again a 13-year-old girl present with very similar issues, but only she had a mass which was 32 week size gravid uterus, and apart from everything, she had ascites and she had a CA125 which was 287.8, which doesn't mean anything. In any peritoneal inflammation, you'll get like that. But she had a beta HCG of 112 and an AFP of 160. This is a patient where you are better off planning a laparotomy along with a gynae oncologist, because what you are suspecting possibly is a germ cell tumor. I will not go into the details, and that is it turned out to be a mixed Mullerian tumor. Now, this is a patient, the second presentation that you will get is a patient who presents with an episodic pain. Now, episodic pain, if it is cyclical, then what you expect is endometriosis. Episodic pain, if it is non-cyclical, with an adnexal cyst, what you need to suspect is whether this is a partial torsion. Many a times it has a torsion of one loop, and then on the second loop happens, the patient gets pain. When the third loop has second, or it untwists and the pain goes. And if you see that, you can see that there was a torsion of one loop, and when it was becoming worse, that is when the patient was getting pain. And when again it twists, has a second twist, that is when the patient complains of pain. When it untwists, the pain goes away. Do not sit on this episodic pain for long, and again you can go ahead and do a cystectomy. I will skip this, and essentially the whole point is to see that there would be patients who will be presenting with torsion, patients will be presenting, some of them will present with malignancy, but if you have your history taking, your examination, your tumor markers and your imaging right, most of the time you will not go wrong in deciding whether to go in for a laparoscopy or a laparotomy. What I want to move on from here is if it's a dermoid, the only thing to say in dermoid is that avoid spillage. And if it is a large dermoid and you think spillage is going to happen, then what you can do is put in a bag, put the dermoid in the bag, and then start operating. Please remember that the dermoid tends to bleed during near the hilum, and this is near the hilum. The more you cauterize, more follicles will be lost, and that is why it is very important to be minimalistic with your energy sources, and number one, and number two, that stay in the correct plane. If you stay in the correct plane, it will bleed less. And lastly, I will speak on endometrioma. If you see the traditional management, we were always taught that any ovarian endometrioma which is more than 3 centimeter should be operated if there is pain or subfertility. However, if you see on the management of endometriosis, the ethos of the whole world is changing. And if you look at the last guideline from ESHRE, you will see that there is actually at the present moment no cut-off size. If somebody presents with a larger ovarian endometrioma, you can still go ahead and give her a medical treatment. If she responds to a medical treatment and the endometrioma doesn't grow, then you can keep her on medical treatment for a long time and postpone the surgery as long as possible. That is the first change in ethos. The second change in ethos is that if it is a patient of infertility with an ovarian endometrioma, and there is no pain, then you really do not need to operate. You will operate only if the endometrioma is so big that the infertility specialist is having problem getting access to the ovaries. Otherwise, you will not. The third important thing is that the first surgery is the patient's best opportunity in terms of recurrence, in terms of fertility outcomes. The first surgery should be done by somebody who's skilled at managing endometriosis. There is no role of preoperative adjuvants. A simple aspiration of the cyst is not recommended. Your two options are a cystectomy or an endometrial ablation or endometrioma ablation, where you aspirate the cyst, irrigate the cyst wall, and then you use a laser vaporization of cautery. Again, published earlier this year in British Journal, it shows whether you use a laser or a bipolar electrocautery, it doesn't make any difference at all in terms of recurrence or in terms of fertility. So essentially, if the patient is complaining of pain, then you are better off doing an cystectomy, provided the ovarian reserve is good. If the ovarian reserve is bad, or if it is a repeat surgery in a patient who's desirous of fertility, then you are better off than doing an irrigation and vaporization. But with irrigation and vaporization, there will be less ovarian damage, but there will be early recurrence. Whether with cystectomy, there will be less recurrence, but there will be some destruction of the ovarian cortex. And that is why Donis has suggested the combined excision and ablation method for large endometrioma. And here what you do is you aspirate the cyst, irrigate the cyst, and you enucleate the cyst till you reach the hilum. And hilum is a place where they will lose the maximum of ovarian cortex. And once you reach the hilum, you cut the cyst wall with a pair of cold scissors and vaporize at the hilum either with a laser or electrocautery. They have published this in Fertility Sterility on 2 occasions, and they've shown that this gives you a good balance between reducing recurrence risk and not compromising with the fertility outcome. And endometrioma with subfertility, I've already spoken about that. If it is primary and if the patient has pain, or if the infertility specialist is having problem in access, then we'll go and operate. If the patient is, if it is a secondary surgery, then there is no benefit. It is best to go for ART. And we need to discuss sometimes that we possibly need to do some amount of fertility preservation in terms of oocyte retrieval and freezing before operating on an endometrioma if their fertility is already compromised. And this is, I put on the slide that ART and endometrioma, what are the benefits of operating or not operating. Earlier, we used to think that it does not impair IVF success rate, which means that if you operate, although the number of eggs retrieved on IVF will be less, it actually doesn't affect the clinical pregnancy rate. Also, it prevents a rupture, it facilitates oocyte retrieval, avoids contamination of follicular fluid with contents, which now at the present moment we know that it doesn't make any difference to the pregnancy rate whether the follicular fluid gets contaminated with endometriosis fluid. Also, if it detects occult malignancy or prevent progression. So which means that if it is a large endometrioma with infertility, we will operate. If it is pain, we'll operate. If we have any suspicion of malignancy, we'll operate. But otherwise, we will not operate because our LOC, ovarian cystectomy prior to IVF, does not improve the pregnancy rate. Plus, you are increasing the risk of surgery and the potential reduction of ovarian reserve. This is a very old paper from 2006 in Human Reproduction. And whenever we in doubt whether an endometrioma should be operated, endometrioma with IVF, I say that this gives you a very good view. Previous intervention if the patient has had a previous intervention for endometriosis, her ovarian reserve is compromised, she has no pain. If it is a bilateral disease and no sonographic feature of malignancy and no rapid growth, then it favors an expected management and going for ART. On the other hand, if the patient has had previous surgery for endometriosis, if a patient has not had a previous surgery for endometriosis, if the ovarian reserve is intact, if there is presence of pain, if it is a unilateral disease, if there are presence of sonographic features of malignancy like solid areas, or if there is rapid growth, it is better to go in for a laparoscopy. I will go into take-home messages. Evaluation of adnexal mass is essential to estimate the risk of malignancy and plan the subsequent management. History is very important along with the TVS and CA125. IOTA simple ultrasound rules, that should be your most important take-home message today, which is the best triage tool in terms of usefulness. RMI is useful only in selected situations. Further imaging and tumor markers are useful in inconclusive as well as in high-risk cases. Thank you very much.
Thank you, Dr. Bhaskar Pal. That was a very exhaustive review of adnexal masses. The adnex tool was something new. That was, and it was a very comprehensive coverage of the subject. Dr. Niranjan, are you handling the questions? Because they aren't coming to me. So do we have time for questions, or are you handling the questions? And then we'll move on to our next speaker. Niranjan, you're muted. Niranjan, you're muted.
Actually, right now I am in two programs. One is the high grade, which has been going on since 9 years, and now I am just finishing that.
Okay.
Marathon thing, but that's what we are doing. Yeah. There is one question by Dr.
We are running late.
Okay. Okay.
Okay.
Thank you. Thank you, Bhaskar. I hand over the mic to Basap.
Yeah.
Yeah, I just want to say, I just wanted to add one thing that when Niranjan was talking about Dr. Me on Bashav Mukherjee joining from the car, please do not join a Zoom call from a call if you are driving. And please remember, the other day, myself and today, Dr. Bashav Mukherjee, we were not driving ourselves, and that is why we could connect.
Thank you. Thank you. That's fine. And let's move on. We have our next
Thank
very
you,
interesting
Pasha.
lecture.
Thank you, Niranjan. And
Thank you.
I wish Niranjan all the best for his ensuing elections in IIG Treasurer. He's a very capable candidate, and all the best to you, Niranjan. He's
Thank
a
you so
professor, Professor Niranjan Chauhan, with 50 publications, and he's doing a lot of endoscopy courses at Sion Hospital. And you heard about the high grad today also. So all the best, Niranjan.
Thank you.
Thank you, Dr. Bhaskar Pal. We move on. Dr. Jaideep Tank. I'm sure that there'll be the Dr. Jaideep Tank's biodata will come up. Yes, here it is. And he is the present Secretary General of FOXI. All of you know him very well. Immediate past President of MOGS, Chair of the FIGO Committee for Safe Abortion, Deputy Secretary AOFOG, and several other organizations, skills, and to his credit. Dr. Jaideep Tank will be enlightening us on ovulation induction beyond in a non-IVF situation. So something for a lot of general gynecologists, infertility management outside the purview of IVF. Dr. Jaideep Tank, we are all ears. We want to hear from you. I'm sure you can share your screen and we take it forward.
Thank you very much, Basa, for that kind introduction. And before I begin, I must thank Niranjan for inviting me for this quite wonderful program. Niranjan, I have known since several years, but I got to know him really well when he was my secretary and I was the president of MOGS. And I must again appreciate and thank Niranjan for all that he did as the secretary of the MOGS. Even now you can see he's busy toggling between two programs, and I really don't know where he gets the energy from to manage so many webinars. So Niranjan, all the very best.
Thank you so much. Thank you. Welcome.
I'm going to talk briefly about ovarian stimulation in non-IVF cycles, and it's time for me to ask the two most famous questions since the lockdown began. Am I audible and are my slides seen?
Yes, sir, you are audible.
Yes.
Thank you, Kavita. Thank you. So I'm going to speak briefly about ovarian stimulation in non-IVF cycles. I understand I have around 15 minutes to cover this fairly extensive topic, and I will try and make sure that I finish in the next 15 minutes. I'm going to start with the slide, which I quite like, and this is actually a screenshot of a Medline search that is done for, as you can see, ovarian stimulation for IUI. What interests me a lot in Medline searches is, besides the content of the search, is always this little graph which comes up on the side of the Medline search. And this graph actually tells you about the number of articles. Yes, Atul?
Your slides are not moving as of now.
Okay, sorry. Okay. I will log out and log in again. 1 second.
Now it's seen.
What about now? Huh?
Now it's seen. Yeah, now it's seen.
Can you see the slide changing, Atul?
Have you changed any slide?
Yeah, you should now be seeing CC mechanism of action. Are you seeing that?
No.
We're seeing a different screen, Jaideep. You need to stop share and start share again. We are seeing a different screen of yours.
Okay, I hope you're not seeing any confidential stuff on my laptop.
Maybe, we do not know. It had PubMed written and many things are the other things written on it.
Okay, let me share through my desktop. Maybe that might be easier. All right. So can you see the slide changing now?
Yes.
You should be seeing CC mechanism of action.
Yes.
Yeah. All right. Thank you very much. Okay. It was. All right. Okay. Sorry about that. Basav, I hope you'll excuse those couple of minutes.
Anything for you, Jaideep.
Thank you. So this graph actually shows you the number of articles that have been published on the topic that you are searching for year on year. So if you have a graph which starts tall and then is going down, it obviously means that the number of articles that are being published on the topic that you are searching for are diminishing every year, and therefore perhaps the topic is not of much interest because either all the issues which surround the topic have been resolved or that topic has outlived its usefulness. But if you see a graph like this, where it starts small and then keeps on going up, it means that a lot of articles are being published on the topic that you're searching for, and therefore there is a lot of interest in the topic that you are searching for, as is evident as per this graph. So we'll talk a little bit about oral ovulation induction, clomiphene, letrozole. We'll then move on to the use of gonadotropins in non-IVF cycles and then conclude the presentation. Two or three important things about clomiphene is that one, the half-life of clomiphene citrate is around 6 days. The clinical significance of this is that there is no point in calling patients for an ultrasound till at least 6 days after the last dose of clomiphene citrate because the LH surge is very unlikely to happen before that given the half-life of clomiphene citrate, which means that there is no sense if you're giving clomiphene from day 2 to day 6, there is no sense in calling patients on day 9, 10, etc. You have to call the patient for the first time 5 days after the last dose of clomiphene citrate is administered. The second is that although clomiphene is famously known to have two isomers, whether you use a preparation with one or two isomers makes no difference because although zoo-clomiphene lasts for a longer time in circulation, it's of no clinical consequence. What clomiphene essentially does is fools the ovary and it fools the pituitary into thinking that estrogen levels are low, and because the pituitary thinks estrogen levels are low, it produces more FSH and therefore causes more recruitment and then the growth of those more recruited follicles. So some common clinical questions with regard to clomiphene: how much clomiphene to use? The ideal answer should be as little as possible, which will evoke a response. But this is not really possible unless you experiment on the patient for 2-3 cycles. What we do practically is always start with 100 milligram of clomiphene. If the patient responds in a high fashion, you can always cancel the cycle and taper the dose later. But I must say that we have hardly found any occasion to do this. When should you start clomiphene? Quite obviously on day 2 or day 3 latest of the cycle. If you start it any later, there will be two problems. One is that at the time of ovulation, you will have too high a dose of clomiphene available in the system, which will affect the endometrium adversely. And two, you will be too late to recruit a larger number of follicles, and then you will only have the clomiphene working to grow what is already recruited, by which you are almost defeating the purpose of that oral ovulation induction. The big question is, should you give luteal support for all cycles? It's my view that it's not a bad idea to do so. It's not a bad idea to do so for the following logic. The logic is, when you give a trigger, you give the trigger usually of HCG. HCG has got two units, the alpha unit and the beta subunit. It's the alpha subunit which is biochemically similar to LH and essentially makes the follicle think that an LH surge has taken place. What happens when the LH surge takes place? Metabolism within the ovary shifts from granulosa cells which produce estrogen to theca cells which produce progesterone. Anything which affects the shift will essentially cause an idiopathic luteal phase defect. So when you have an intrinsic LH surge, that LH surge is modulated by the available levels of estrogen. But when you give a shot of HCG, there is no modulation of the LH surge. It's therefore quite possible that by giving an HCG injection, what you're doing is hampering the shift of theca cells from granulosa cells, thereby hampering the shift of the metabolism from granulosa and estrogen to theca and progesterone. By doing so, what you're essentially doing is producing what I like to call an idiopathic luteal phase defect. Luteal phase defects are notoriously difficult to measure and are usually diagnosed post facto. That means after they have already occurred. So We tend to give luteal support for all cycles where we use a trigger. Should you do clomiphene and IUI cycles? There is good evidence to show that adding an IUI to any form of oral ovulation induction does not improve pregnancy rates unless there is a reason to do an IUI, like a mechanical reason, for example, hypospadias, for example, erectile dysfunction, for example, cervical factor dysfunction, like there's been a biopsy and cervical rheology is abnormal. How many cycles of clomiphene to do? The literature says 6 to 9, but in real life, we don't tend to do more than 4 cycles. The last point I'd like to make here is that it's very important to distinguish clomiphene resistance from clomiphene failure. Clomiphene resistance means you have given the maximum possible dose of clomiphene and the patient has not ovulated. Clomiphene failure means the patient has ovulated but has failed to conceive. So when you make a diagnosis, be very clear about this, because the treatment for resistance versus failure is quite dramatically different. Obviously, clomiphene has limitations, and its biggest limitation is that although it has ovulation rates in excess of 80%, pregnancy rates are only around 30 to 40% cumulatively. We were always there for looking for an alternative, and we thought that we had found it when we found letrozole with this publication. Letrozole is quite different from clomiphene. The end result is the same, that it thinks the follicle thinks that E2 level is low, but the way it acts is different because it is an aromatase inhibitor and it has no action on the estrogen receptors. Moreover, because of its short half-life, that's around 2 days, normally letrozole will have a much moderate effect and therefore prevent an overzealous discharge of FSH, which will ultimately cause a monofollicular response more often than clomiphene citrate. There were concerns about letrozole and congenital anomalies, but that has been cleared now, and I think that there is good and robust data to show that letrozole does not cause congenital abnormalities. There are several guidelines now, and what the guidelines essentially is that where you would like monofollicular response, for example, in patients of PCO or patients who have a very high BMI, letrozole should be the drug of choice in the first instance. Mind you, I'm not saying you can't use clomiphene for these patients. You can, but first use letrozole, and if letrozole doesn't work, then only move on to clomiphene citrate. So the current dose recommendations for letrozole from the drug controller are 2.5 milligram once daily for 5 days, from day 3 to day 7, for 3 consecutive cycles or till occurrence of pregnancy. The Drug Controller of India does not recommend more than 3 courses of therapy for letrozole, and they also recommend that the dosage or duration for therapy beyond 2.5 milligram per day for 5 days should not be undertaken. There is evidence to show that doses higher than that, given for longer periods of time, may be quite effective. However, we live in India and we should follow the recommendations of the drug controller. We'll move on now to gonadotropins. And I think the first thing I need to say is that when you're talking about gonadotropins, it's not only the addition of gonadotropins, but the combination of gonadotropins with IUI, which results in the best success rates. Moreover, the addition or downregulation for an IUI cycle with GnRH does not really appear to be show any benefit. Counterintuitively, on average, HMG has been found to be more cost-effective than clomiphene citrate. Why? Because pregnancy rates are higher when you use HMG with IUI rather than CC with IUI. So for those who don't do gonadotropin cycles, I hope that this will be particularly useful. In my view, the most important thing about gonadotropins and whether you use them in IUI or IVF is the starting dose. For me, the fate of a cycle is actually decided with the starting dose. We tend to pay much more attention to the later half of the cycle is when our ultrasounds and all come up. But the truth is that the fate of the cycle is decided with the starting dose. And how do you decide the starting dose? You decide it on the basis of the age, antral follicle count, AMH, and the previous response. I have a small little table in the next slide, which I will show you. The big difference between a pure gonadotropin cycle and oral ovulation induction or natural cycle is that stimulation with gonadotropin typically lasts for 10 days. So you expect ovulation a little earlier, you expect the follicle to be ready a little earlier, not on day 14, but close to day 10, 11. So your average stimulation is going to be 10 days. You should trigger, and then you should ideally give a luteal phase support. So how do we decide a starting dose? Again, this is a rule of thumb. There can be more individualization, but I have found it useful to think this way. So you take into account age, that's less than 35 or more than 35. You take into account AMH and anti-follicle count by saying non-PCO or PCO. So less than 35, non-PCO 150, PCO 75. If she's more than 35, whether she's non-PCO or PCO, you start with 150, and that is because age is probably the most important factor for ovarian reserve. And with increasing age, your ovarian reserve will go down. So even if she's PCO, that age will attenuate the effect of the PCO, and therefore you should start a little early. We normally give 5 days of gonadotropins and call the patient for a sonography and dose adjustments on the 7th day. On the 7th day, you'll have two groups of patients. One group where follicles are there of more than 10 mm, the other group where follicles are less than 10 mm. If they are less than 10 mm, then you need to increase the dose. If she's PCO, increase it by half of what you started with. If she's non-PCO, simply double the dose. If there are more follicles of more than 10 mm, and if there are 2 to 3 follicles, continue the same dose. You hit the right starting dose, carry on. If there are 4 to 6 follicles, keep the dose the same or taper depending on your comfort level. And if there are more than 6 follicles, taper. I've written there look for OHSS, but in truth, what you're worried about is not really OHSS, but multiple pregnancy. So if you're going to cancel a cycle in this instance, you're not canceling it because you're worried for OHSS, but you're worried about multiple pregnancy. When the lead follicle is 18, that means the first one is 18, give the trick. Don't wait till the last one is 18, and you will find that you have much lower incidence of multiple pregnancy. I don't recommend this, but if at all you would like to use an oral ovulation induction agent, you can use letrozole, not clomiphene, and this is the way to use it. Whether to use an antagonist or not in IUI cycles is still a matter of debate, but there is some recent evidence to show that if you use antagonists on the last 2 days of stimulation in a non-IVF cycle, you will have a slightly higher pregnancy rate. As far as the trigger is concerned, currently we use HCG and we tend to use around 10,000 units. And using lesser can also provoke ovulation, but sometimes can also fail to provoke ovulation. And when you're not worried about hyperstimulation, I think there is no reason not to use the adequate dose of HCG. Remember that if you are worried, you should withhold the dose. If you withhold the dose of HCG, nothing will happen even if you have multiple follicles. About monitoring, I'm fond of saying that even in IVF cycles, the first blood test we do is serum beta HCG. So for us, ultrasound has always been the gold standard of monitoring, and that's what we continue to do. In a typical IUI or even IVF cycle, we normally call the patient just twice during monitoring ovarian stimulation, and we have found that to be quite enough. A lot has been said about supplements, but there is clear evidence to show that perhaps supplements are not really as beneficial as one would have thought they would be, including the very famous metformin. At one point in time, I was seeing metformin being handed out like candy, but now we know that unless there is a biochemical, hormonal imbalance, metformin may not really be very useful. For me, counseling really remains the most important part of fertility treatment. A lot of fertility specialists will tell you, patients will conceive irrespective of what you do. If they are with you when they conceive, you will get the credit. And for me, counseling is the best way to keep the patient with you. And one of the important things I've found during counseling is really to do the whole thing, whole counseling at the beginning and the end of each treatment cycle. There is no consensus on the exact number of cycles that you should do with IUI and gonadotropins, but on an average, I would have to say, doing more than 4 or 5 cycles of the same treatment as a general principle in infertility is unlikely to result in anything good. Of course, it varies by indication. For example, if you have someone who has a very low fertility potential, like a low AMH, then you would tend to move on much faster than you would otherwise. This is my last slide, and I think I've taken 16 minutes. But this is a slide which is very close to my heart because it really speaks to me on a very emotional level. This is a baby born to a lesbian couple in the UK. And as they have said, after 4 years, 7 attempts, 3 miscarriages, and 1,616 shots. What this couple did was they saved all the syringes and needles of all the treatment that they had undergone. And when the baby was born, they wrapped the baby in this pride blanket that you can see and surrounded it with the syringes and needles. You can see this picture went quite viral on Facebook. And I'm very fond of this picture because it speaks to me about how much our patients invest in fertility treatment. And when I say invest, I don't mean simply financially, I mean emotionally. I mean so much of a part of their life that we owe it to them to do the best that we can. Thank you very much. I can't see Basad. I think he has left.
Yeah, yeah. Hi, Jaideep. He just called me. He has an emergency cesarean section, and wonderful presentation you have done, Dr. Jaideep, on ovarian stimulation in IUI.
Thank you.
We are very thankful to you, and it's really pleasure that in spite of your busy schedule, all of you have come and being a part of this. We have crossed more than 1,800 viewers now. They are live, and it's amazing on a Saturday weekend when IPL is going, which is going to start at 7:30. I'm trying to wind up as early as possible, but I know you have your all OPDs running, Jaideep, from 4 o'clock, and thank you so much for being there. There are presently no questions, so I am assuming that your lucid presentation has gone down well with all the viewers. So thank you so much for being there, and Dr. Bhaskar Pal for being
Thank
there.
you, Niranjan, and all the best.
Now I would like to hand over the mic to the next moderator, and it's a pleasure to introduce Dr. Kavita Bapat. She's the Vice President of Foxy, a leading lady from Indore. Uh, we know that she's practicing a gynecologist from 1987 onwards. She was the breast committee chair from 2016 to 18. She has got numerous honors and awards in last 30 years. Highly experienced. I'm very amazed with the way she speaks and the way she concludes her sessions. She's very learned. She's very popularly known for her organizing capacity and the skill which she had organized. I remember the breast committee World Congress which she had done about 1.5 years back, where more than 2,000 members from all over India and the world had come to this Indore, and that made us very positive, inspiring for her to claim AICOG of Indore. So I welcome, madam. Your CV is too long and too big. You are the owner of Bapat Hospital. And
thank you so much, Niranjan. Thank you, both ho gaya. Thank you so much for everything, and all the best for your future endeavor. You are such a hardworking person and a compassionate and what you call it, very perseverance is high. Now, please show me the slide of Atul Ganatra sir so that I can introduce him.
Thank you, madam.
Thank you so much, Niranjan, for giving me the chance to be as a moderator with your esteemed discussions. Dr. Atul Ganatra, Vice President Foxy. I just like this type of slides to be introduced someone here. Who has given that slide of mine? I don't know.
myself. Thank you so much.
So the point is, Dr. Atul Ganatra is Vice President Foxy, Treasurer IAG, and Member Managing Committee MOGS. But the best part of Dr. Atul Ganatra is that he is doing great job, great surgeon, and a great academician, and lot many case series he's having, and all the time he gives the lot many things, and he's going to talk about the energy sources, and we all know
that he's going to speak great about it. And we know that the energy sources are the very, very important thing in endoscopy. It includes dissection, ablation, destructive techniques, whatnot, and everything is there. And without energy sources, we are not able to do. So welcome, sir.
Thank you, Niranjan. I think Niranjan is the Arnab Goswami
Over
of.
to you, Dr.
Thank you, Niranjan, the Arnab Goswami of Webinar TV. I think thank you, Kavita. Kavita is capable of removing even tonsils vaginally, I think. And difficult to speak after two people who are probably going to be president-elects in future. But I will try and keep up to my time. And energy sources is a subject which is very close to my heart. And I would start by saying that if you always do what you've always done, you will always get what you've always got. Which means that we need to progress at every time. Progress is the need of the hour. I'm going to be talking on recent modifications of electrosurgery. And before I start, I would earnestly request everybody to read this article, Principles and Safety Measures of Electrosurgery in Laparoscopy. And we are aware that 90% of complications that take place in laparoscopic or hysteroscopic surgery are as a result of thermal energy. So I think all of us must be very, very clear about our concepts of electrosurgery, not from the person who's selling the electrosurgical unit, but we must be aware of the benefits of electrosurgery, the side effects, the principles of electrosurgery. So the history of hemostasis, cautery, prehistoric, heated rocks and metal. We used heated rocks like copper sulfate. Ligature came in the 22nd century. Staples in 1826 in France. Von Spets in 1921 got the GI stapling device. Clips came in 1917 in neurosurgery. Electrosurgery in 1926 was introduced commercially in the United States of America. Laser in 1940, and the development began in USSR. Ultrasonics came in 1990s. I think when I had just passed out, laser had just come in for endometriosis surgery. I still remember Dr. Prakash Trivedi using the laser in endometriosis surgery. Vessel ligation is a critical component of surgical dissection, and we are all aware every time we have a difficult hysterectomy, we have a difficult myomectomy, the endoscopic surgeon says ligate the uterine artery. Whether you have a cervical pregnancy or an isthmocele or a large fibroid, a broad ligament fibroid, multiple fibroids, I think what they tell us is we have to see that we can ligate the uterine artery well. So before I begin, I want everybody to know every aspect of electrosurgical methods that we have. We have the monopolar electrode, the bipolar electrode, the monopolar electrode, the circuit is complete when the electrode falls on the patient plate and then comes back to the electrosurgical unit. The bipolar works between the two blades of the bipolar forceps, the laser and the ultrasonic coagulator. Now, mind you, all these four modalities can ligate vessels up to about 3 to 3.5 millimeters. So if you have a large vessel which is more than 4 millimeters, going up to about 7 millimeters, is when your scare comes in. That is when they say ligate the uterine artery or ligate that particular vessel. Electricity always seeks the ground source and seeks the path of least resistance. That is a very, very important point. Here, four important points that we need to remember. What is current? It is the flow of electrons during a period of time measured in amperes. I want all of you all to by heart this because this is something that we are going to come to. Here we said electricity takes the path of least resistance, the ground, and then the patient plate in between. Circuit, the pathway of uninterrupted flow of electrons, which must be complete for a flow. So this particular surface must be complete. Fortunately, we have smart cauteries who don't work in monopolar. When we are using monopolar, if the cautery plate is not in place or the wire of the cautery plate is not working very well. Impedance is the resistance that is offered by the tissue, obstacle to the flow of current measured in ohms, or the resistance that is offered. So peritoneum will offer least resistance, and we are cutting the Meckenroth ligaments, it's going to offer a lot more resistance. And the voltage, the force with which the current passes through the resistance measured in volts. So this is the most important part. I think the current, that is the flow of electrons measured in amperes, and the voltage, the force with which the current passes, which is measured in volts. So when we come to bipolar cautery, we see that the current is less than 1 ampere. So it is the flow of electrons during a period of time is less than 1 ampere. But the force with which it pushes is around 300 to 1200 volts. That is very, very important for us to know. So bipolar may be a little more safer than monopolar. Monopolar current, continuous cut and interrupted waveform. Current again less than 1 ampere. What is 1 ampere? That is the flow of electrons during the time measured in amperes. But the voltage, see the voltage that it goes when you are using coagulation current, the voltage, that is the force with which the current passes, is between 3000 and 9000 volts. And in the cutting current, it is 1350 to 4000 volts. Why is this important? And that is why they say that if you're using a vaginal tube and using a monopolar current to open the vault of the vagina, do not use coagulation current. The charring is much more, the dead tissue, the desiccation is much more. Use cutting current, because otherwise you're causing a lot more necrosis at that area, because the current, depending upon your cautery settings, will be between 3000 to 9000. Particularly important for the vault. And that is why sometimes when you use coagulation current, the vault gives away in spite of having taken sutures. Whereas vessel sealing is a completely different technology. Electrosurgical technology that combines pressure, energy to create a seal. It has a clamp. You seal that area with a clamp. It has a knob. It makes a clicking sound, and then you pass the current. It is reliable, consistent, permanent vessel wall fusion, minimal thermal spread, reduces sticking and charring, seal strengths higher than other energy-based techniques. I'll come to it as to why. And comparable to existing mechanical techniques, that is ligature. So this is the kind of feel that you get when you use ligature or you use any other vessel sealing device. Now, why does this happen? We saw that when we used monopolar or bipolar, when we used monopolar or bipolar, the amperes, the number of amperes, that is the flow of electrons during the period, was just 1 ampere, whereas when we're using a vessel sealing device, the ampere range is about 4 amperes. And the force with which the current passes through is as low as 180 volts. Remember, at coagulation current, it is around 8000 volts. So this is why it is much safer. There is less lateral thermal spread. Lateral thermal spread is maximum with coagulation current. And this 4 amperes is what helps you create a seal on the two walls and brings the two walls together and fuses them together, which causes least amount of charring and best amount of hemostasis. And here, the vessel sealing device scores over the conventional devices when you have a vessel between 4 and 7 millimeters if you have a very large uterus. Instruments, high pressure, open, reposible, laparoscopic. You even have reusable ones in the Indian market. Otherwise, they are disposable. Of course, in the Indian market, we ETO them and use them. So, monopolar coagulation, low ampere, high voltage, up to 9000 volts. So, same with bipolar, again, low amperes, high voltage. Vessel sealing, high ampere, low voltage. That's why lateral spread is less, charring is less, thermal spread is less. And this is the kind of seal that you get when you use the vessel sealing device. There is hardly any lateral spread. System operation applies optimal pressure on the vessel tissue bundle. So it brings the two tissues together and then uses high ampere. That is, the current that is passed is around 4 amperes, which brings about a seal at this level. And then it flows the current at about 180 volts, which brings about the hemostasis. That's why the lateral spread is much less. Plus, there's a smart cautery. It stops on its own when its job is done. Delivers pulse energy with continuous feedback control, senses tissue response to complete, and stops the cycle on its own, which does not happen with monopolar or bipolar. Seal characteristics, plastic-like consistency due to collagen remodeling, distinctive possibility, translucent seal zone, which stands greater than 3 times normal systolic pressure. Even if you build up the pressure on the vessel, the seal doesn't open up. And that's why it is extremely useful when you have a large vessel. I think it's a treat to use it in a hysterectomy free to use it while you are doing an omentectomy or a difficult vessel that you're tackling with. We now move on to the next electrosurgical unit, the harmonic, that is the ultrasonic energy platform for cutting, coagulation, soft tissue in laparoscopic and open surgery. There are a variety of probes available. There is enhanced patient safety, better clinical outcome, because basically also uses bipolar energy. The energy is between the two. One is the active channel, the other is the non-active channel. So it has kind of a handpiece mount, silicon nodes, and a blade extender, and the blade vibrates at about 55,500 times per second. And the ultrasound wave transferred to the blade extender and the handpiece mount causes the electrosurgical energy to pass through. What it does is this ultrasonic energy brings about protein coagulation. It forms a coagulum. So basically all forms of electrosurgical units, barring the vessel sealing device, works on the principle of forming a coagulation. That is the most important part. Again, as you can see, the lateral spread here with monopolar is much more. Here, lateral spread is much less. Definitely an excellent dissector. So harmonic is an excellent dissector. But if it comes to vessel sealing, I think it is a little difficult unless you are really good and an expert at using the harmonic, where you may have to pass the current at about 2 or 3 places. So energy in the ultrasonic variety, controlled and precision over cutting and coagulation, minimal lateral thermal damage, multifunctional instruments, less tissue sticking, less smoke formation, no stray energy, no neuromuscular stimulation, no electrical energy to or through the patient. So basically in the bipolar devices like ligashore, harmonic, or the conventional bipolar, you don't need to use a patient plate. You need to use the patient plate in monopolar current. This is the kind of Gen 11 that we have. It also has what is called as an end seal, which is also a vessel sealing device. I'm not very, very comfortable with it, however. The third variety, the Thunderbeat, which is extremely useful because it has both ultrasonic energy and the vessel sealer device in a combination in 2 switches, and that's why it has a great advantage. So best in class versatility, can seal up to a 7 millimeter vessel and can be used for dissection as well. So it has 2 modes. It has a seal and a cut mode, and it has a seal mode, that is the vessel sealing mode here. So it has a bipolar and an ultrasonic device here, and I'm sorry. So you don't need to keep changing your instruments. I have personally found this instrument extremely useful, but not as sturdy, because I've used it in a couple of workshops, but I've broken the instrument in the first sitting. Maybe I'm just not used to it, but there are others like Dr. Modi who's extremely comfortable using it. So in the seal and cut mode, you use the device on level 1, and in the seal mode, you use it on level 3. Again, the seal mode can seal a vessel of about to 7 millimeters. My favorite, the biclamp, that is the Urbe device, autoclavable, reusable, 5 millimeter vessel sealing device. Beautiful instrument. I think I'm in love with this instrument. I have it for the last about 8 or 9 years. The most important advantage is that it is autoclavable and reusable. Very little charring. Your tissues are white when you use them. All the other features, like the bipolar forceps, again a smart cautery. The vessel sealing, once the job is done, the machine stops working, and again that it can seal up to vessels of up to 7 millimeters in diameter and a maximum burst pressure of about 950 millimeters of mercury. Being able to produce such secure seals open up possibilities for new minimally invasive techniques, such as even uses in vaginal hysterectomy, hysterectomies, and other vessel sealing devices. In fact, the robot that we are now using, we've done about 5 or 6 cases at Fortis with the robot, has this biclamp, Urbe biclamp. And actually, when we use this in robotic surgery, we hardly need to use any other device, because each device is, for example, if you use the harmonic for a robot, it costs around 40 to 50,000 rupees, and it is a single-use device, whereas this Urbe bipolar can be used up to 10 uses. In conclusion, a thorough knowledge of the fundamentals of electrosurgery by the entire team in the operating room, not only the operating surgeon, is essential for patient safety and for recognizing potential complications. New Hemostatic technologies can be used to decrease the incidence of complications. More important, making the surgery safer for all of us. Of course, know thyself. You are the best judge as to what you are comfortable with. And I think if you give me an AK-47, it's useless. So I think you need to know your device. You need to use. You could use a shearer. You could use bipolar. You could use just the biclamp and finish a whole hysterectomy. You just need to be comfortable. But you must know everything about that device, more than what the marketing guys know. Thank you very much.
Atul, wonderful.
Thank you so much, Dr. Atul Ganatra. I agree with you that the gynecologist using this tool should be aware of the potential benefits and the dangers of the instruments, and especially the biophysics, especially by the female surgeons. They should also understand the energy source, the tissue effects, and the complication. Thank you so much for the energy sources. Over.
Thank you so much, Dr. Kavita. And Atul, you have wonderfully completed the chapter and the lecture on energy sources. I remembered you had done a lot of efforts to take out IAG newsletter, and there was a big chapter in that connection. Dr. Kavita, are there any questions you want to ask Dr. Atul? Or we will proceed. There are no questions right now. Thank you so much, Dr. Atul. I request now Dr. Rishma Pai Madam to come online.
Thank you, Niranjan. Thank you, Dr. Kavita. Thank you.
Thank you.
Hello.
Dr. Rishma Pai. Yes. Dr. Kavita, can you please introduce Dr. Rishma Pai Madam? I think we have some connection issue from Indore. Dr. Rishma Pai Madam is the president of the Mumbai Obstetrics and Gynecological Society, president of FOXY 2017, president of ISAR 2018-19, president of IAGE, that is Indian Association of Gynecological Endoscopists. I remember during her tenure, we had done a lot of efforts and a lot of work to impart training of endoscopy.
Hello, I am there. Sorry, my connection was unstable.
Okay, yes, madam. Please take
sorry, extremely sorry. Niranjan, pata nahi 2 minute connection gayab ho gaya, and I am thankful to Dr. Atul Ganatra that the gynecologist should know all about the biophysics and everything about the end of this energy sources, and complications should be looked out. So I welcome Dr. Rishma Pai, President Mumbai OBGYN Society, the best and the dynamic and very warm-hearted person whom I know since long my journey in FOXY. She is the president FOXY in 2017, and I worked under her. I really enjoyed her. She is also the president 2018-19 of the ISAR and the treasurer of International Federation IFFS and consultant gynecologist. But the most of the thing, warm and a very, very sweet person. Welcome, madam. Hello. Welcome, madam. Am I audible? Connection ki baat.
Madam, you are audible.
Yeah, thank you. Sorry. Welcome, Reshma, madam.
She will join us.
Okay. Okay.
Yeah, madam has joined.
I am right here. I just need to share my screen. So give me a second. Oh God, okay. Sorry, I actually can't see the share screen bit at all.
Niche, madam.
Sorry.
Support, can you help Dr. Rishma?
I think I should be.
Ma'am, are you in Zoom application right now?
Sorry? I can't see the share button at all for some reason.
Please go to my Zoom application.
I'm already there. I just cannot see the screen share.
Screen share, green icon.
No, I know where it is. It's just not showing up right now. It's getting camouflaged every time. Okay, sorry.
So you have to press Alt tab. Alt tab to go to the Zoom application.
I think somebody will have to help me. For some reason, it is not opening. Let's see if it is opening. Is it opening?
Yes.
Can you see me and hear me now?
Yes.
Yeah, we can see the slides.
Okay, perfect. All right. There's a thing saying later, start my video. What should I do? All right, let's see how this goes. Niranjan, you're there?
Yes, yes. Yes, madam, I'm here.
Good evening. Thank you. And sorry for the hiccups.
We understand, madam.
Hello, hi. So let me just go ahead very quickly.
Thank you, madam, for coming today. Welcome.
Thank you. So today we are here to discuss a very important aspect of fertility as far as India goes, and that is improving fertility outcomes in female genital tuberculosis. All of us know what a huge problem it is, especially for our country. And I believe that some problems are really so complex that you have to be really well informed and intelligent to be just undecided about them. So even after so much knowledge, you really can't be conclusive about how to manage certain issues and problems. So incidence, all of us know, depends which part of the world you are in. It may range from as little as 1% in the US to as high as 1 to 19% in certain parts of India. So tuberculosis, we know, is rampant all over India. And in patients who require ART, the incidence is obviously very, very high. And you can see the incidence of female genital tuberculosis in patients enrolled for ART in certain clinics in India was 24%. And almost 50% with tubal factor infertility. So one of the leading causes of infertility in our country is unfortunately tuberculosis. Investigations, I don't even need to go through the basic ESR, X-ray, MAN2. All of us are very, very familiar with that. The PCR test, we have all tried, and all of us know that there are lots of false positive, false negatives. You really can't rely on that test very much. Culture is a little bit better, but sometimes you don't get accurate results. And of course, gene expert is coming in now. HSG gives a classic picture. We've used it for many, many years. Sonography may not. CT may have a little bit of influence. And of course, endoscopy, which is our significant subject of discussion today. So when you look at endometrial tuberculosis, that is what our main concern is, uterus and the tubes and the endometrium. So ESR MAN2 may evoke a suspicion. Imaging, unfortunately, this is one area in which it is not a gold standard. It will help you if there are adhesions in the uterine cavity, if it's very thin endometrium, you'll get an idea. Unless there are TO masses, you will determine. But other than that, difficult to diagnose. HSG, you'll have the typical, distorted contour of the cavity, multiple tubal occlusions, maybe hydrosalpinx, adhesions, etc. Endometrial biopsy, definitely a much better test, especially if you can actually see the typical non-caseating lesions significantly associated with tuberculosis. And hysteroscopy today, I feel, is one of the best tests for endometrial tuberculosis. Most of us rely on that now to diagnose our patients. When you put a laparoscope inside these patients, could be just an unexplained infertility, or you don't know what to expect. And then you typically see this kind of a classic picture, which you can see in the movie here. You may see a very inflamed looking uterus, salpingitis, TO masses, tubal occlusion with hydrosalpinx. There may be some free fluid, serous type fluid, maybe caseation, very often a frozen pelvis or mental adhesions. You can see even the liver. Very often you see that Fitzhugh-Curtis type of reaction around the liver. And like I said, on hysteroscopy, you'll see synechia or destruction, a very pale endometrium, and you know that this is classic of tuberculosis. You can see here the very, very classic picture. So what is the treatment? So just a touch on the treatment, because all of us know that in India, very often the DOTS, that is the directly observed treatment short course, is recommended, where they give 2 drugs, INH rifampicin for 2 months, and then they give INH rifampicin, ethambutol, pyrazinamide for 2 months, and then 2 drugs for the next 4 months. Or you can have a non-DOTS treatment, essentially 4 drugs initially, and then 2 drugs for the next 4 months. That is the standard treatment for tuberculosis. What about surgery? Does surgery have a role to play in genital tuberculosis? Usually avoided because medical therapy is way better. But there may be situations where you need to actually operate a case of tuberculosis, particularly when there's a massive abscess, tuberoarian abscess, where there's pyosalpinx. Sometimes there may be some, you've treated the patient, you want to go back and see whether there's been an improvement in the situation. So you go do a second look laparoscopy. Hysteroscopy, we know sometimes the cavity may be very narrow. We may have to do adhesiolysis, and we may have to do lateral wall, sort of a widening of the cavity. So all of this can be done. But remember, tuberplasty, if you're trying to open the tubes which have been damaged by tuberculosis, it can be dangerous and in fact may flare up the condition, and you may end up with a lot of ectopic pregnancy and such other things rather than any significant improvement. So surgery has a very, very minor role to play in very well selected cases of tuberculosis, not otherwise. And you can see the conditions are so bad. How are you going to improve these conditions? So we come to now latent tuberculosis, and that's been always a big controversy, that you have a diagnosis on PCR. You have a suspicion, you do a PCR, you find a positive PCR. Should you treat these patients? And there are many studies, Indian studies, of course, saying that you should treat these patients because the condition is very early. If you treat it, the condition will not progress and the patient will not get very bad damage because of tuberculosis, and you'll be able to get much better pregnancy outcome. But, and we also know that even if it's latent tuberculosis, the success rates with fertility treatments are very, very poor. But if you start treating every positive PCR, you're going to over-treat many, many patients who may never develop into full-blown tuberculosis. So it's a big dilemma whether you should or should not treat latent tuberculosis. There's a nice study by Dr. Kriplani who compared 100 women, she did an endometrial aspiration DNA PCR and put half of the patients on AKT and half the patients on no treatment. And it was found when they were started on treatment, the pregnancy rates were similar. So with or without tuberculosis, which is diagnosed only by a PCR test, the results were similar. Also, when after 6 months after treatment, again the PCR was done in these patients, endometrial biopsy and PCR, it was found that the PCR was again positive after treatment also. So essentially, the conclusion was that you don't give anti-tuberculous treatment for positive DNA PCR. It is over-treating the patient. So like I said, there's so much debate and discussion on this area, and that throws open so many challenges for us, particularly in patients who are coming to us for IVF, because we know that in these patients, pregnancy outcomes are so pathetic that sometimes IVF is the only option for them. But even in IVF, there are so many problems. Ovarian reserve is less, the endometrial blood flow is pathetic, and so results are comparatively very poor in these patients. So, like I mentioned, ovarian reserve is a major problem. And this is again Jirge's study, where she has said that these patients, even with latent tuberculosis, maybe early stages of tuberculosis, the pregnancy rates are reasonably okay. But there is a lot of effect upon the ovarian reserve, the AMH, the AFC, everything comes down. And these people will have a poor ovarian reserve. And obviously, because of that, their pregnancy outcomes in IVF will be eventually poorer. So if you treat these patients, these latent, these early stages, whose ovarian function is going down, if you treat them with tuberculosis, J.B. Sharma study has said that there may be an improvement in the anti-Mullerian hormone test and antral follicle count. So maybe if you catch these patients early, treat them, you'll be able to prevent the reduction in ovarian reserve. The other important aspect, the endometrium. So ovary is one important aspect, endometrium is another. And all of us know that endometrial thickness is very important. If your endometrium is less than 7 millimeter, the pattern is poor. If there are, blood flow is poor, the chances of pregnancy is very, very low. And so Tuberculosis, unfortunately, has a huge impact on the endometrium. And because of all these factors, you can see that IVF in these genital tuberculosis patients, because they are poor responders, they have very high dose of gonadotropins, endometrium is really pathetic, embryo quality is poor, and so success rates are unfortunately very poor. And you can see that despite the poor rates compared to every other option, IVF is the only resort for these people. So IVF is, compared to all the other treatment modalities, gives you about 17% success rate in comparison with maybe only 4% with fertility enhancing surgery. So it is really both are poor choices, but IVF scores over all other options. And you can see many studies where pregnancy rates are going as high as 25%, 38% in certain studies. So there are possibilities of success with IVF, particularly if the damage due to tuberculosis is not too much. And Dr. Sonia Malik's study had 38% pregnancy rate, which was quite surprising. And she observed that this pregnancy rate is high because they were really doing PCR tests, aggressive treatment, and continuing treatment for long, sometimes up to 18 months. And then if the endometrium was poor, they were straight away, if it was not treatable by hysteroscopy, they were going for maybe surrogacy in certain patients or adoption. And that's how eventually pregnancy rates came high. Because in individual patients, sometimes the results can be quite low. So we do believe that hope is always there. So when the world says give up, hope says try it one more time. And I think it's very important for us as specialists of IVF to give hope to our patients. So what can we do for these patients who are in a very bad situation? How do we improve the ovarian reserve? Fortunately, many new innovations have come in, and I'll talk about some of the practical ones which we are actually doing and which is being done in many cases. One of the things you can do to improve this ovarian reserve is the intra-ovarian injection of calcium gluconate activated platelet-rich plasma. This is something which we are doing in our practice now. We are doing laparoscopic, we are doing transvaginal injection of activated PRP for ovarian reserve. And it has been found that there is evidence of improved ovarian function in all of these patients who receive this therapy. So within 2 to 3 months, there's an improvement in ovarian reserve. Stem cell therapy, it's being utilized everywhere. And the use of autologous stem cell ovarian transplant, ASCOT, that's what it's called, has been shown to give 81% of patients showing an improvement in ovarian function. So again, natural pregnancies have happened in poor responders after doing this ASCOT procedure. So really, there is a possibility that stem cells may have a role to play over here. In vitro activation is much more complex, and this is where all these leading endoscopic surgeons come into being, because what is done, and see this study, it's an amazing study with patients who are completely in menopause, FSH more than 35, amenorrhea for 4 months, so complete menopausal patients. And what was done? Laparoscopic surgery, ovariectomy was done, ovary was removed, cut into strips and frozen. Whenever required, these were removed from vitrification process. They were warmed, cut into pieces, and they were put into the AKT stimulators, protein kinase stimulators. And these small pieces, ovarian cubes, were laparoscopically transplanted back beneath the serosa of the fallopian tubes. And it was seen that after some time, because of the good vascularity in the area, these ovarian tissues started to grow and ovulation happened. And these patients who were FSH levels of 35 actually went ahead and conceived. 4 out of 4 patients, 3 of them conceived. So pretty amazing in vitro activation is possible. And then, of course, few things which are currently happening, which our next generation will surely see, and that is growing for the first time human eggs in a lab from the earlier stages in ovarian tissue all the way to full maturity. This made headlines in the London newspapers a while ago. So you are actually from the very early stages, immature germ cells you can pick up and actually grow them to fully mature eggs. So this is remarkable. And even more remarkable, USA Today headlines saying artificial ovary is being developed for patients, particularly cancer patients. But we know that in our country, tuberculosis is sometimes playing an even more important role than cancer because it's so much more common. And you could actually create a sort of a, scaffolding into which you could implant eggs and actually grow ovarian tissue. And this actually can restore the woman's fertility using her eggs and some donor tissue. And focus on the last line. This work could develop into an artificial ovary in 5 to 10 years. So maybe even the next generation has to not wait. Maybe our generation will see development of artificial ovary. So amazing things are happening on the ovarian front and the damage to the ovary front. What about the endometrium? Do we have radical things to improve the endometrium in these patients in whom it's totally destroyed by tuberculosis? And you can see it's a huge challenge. Every time we see a patient with thin endometrium, we get desperate. We give aspirin, estrogen, we give vitamin E, we give sildenafil, all kinds of drugs are tried. But all of us know that most of these don't work very, very well. So what does work in thin endometrium? One thing which is seeming to help, not really increasing the thickness of the endometrium, but improving implantation, improving receptivity, is the granulocyte colony stimulating factor, that is the GCSF. And many studies, now there are literally many hundreds of studies which are saying that the infusion into the uterus of granulocyte colony stimulating factor has a beneficial role, especially in the cases with recurrent implantation failure. And we've done for many years now, we are using GCSF with reasonably good results. It's not magical, but in well-selected patients, you do see an improvement. Similarly, with the use of autologous platelet-rich plasma, it's the patient's own PRP that we're using. So there's no foreign material going in here. And if you can do intrauterine infusion of autologous PRP 2 or 3 times from menstrual day 10 in the frozen transfer cycle for about 2 to 3 times before the embryo transfer, there is a significant
Hello, Dr. Kavita.
Yes. Hello.
Can you hear Dr. Ishma Pais? I think we have lost connection.
Hello.
Dr.
I'm there.
Kavita,
I'm there. Hello. Hello. I'm there. Hello.
Yes, ma'am, you are audible.
I'm there. I'm there. Hello.
Yeah, I think we have lost
I'm there.
connection.
I'm there. Hello.
For a couple of seconds.
We. Okay.
I am.
Hello.
Yeah. Sorry, I just lost connection for a bit. Okay.
Welcome back.
Yeah. All right. The view that I want. How do I do that? Can you see my screen?
Support, can you help Dr. Rishma?
I have no idea why this is happening.
Don't worry, madam. We will have the support you right away. Support.
Can anybody see me?
Madam, we can see you, but we can't see the screen.
Oh, okay.
Madam, you have to just search for share screen.
Again, share screen?
Yeah.
Yeah, we can see your screen. We can also see the slide.
Okay.
Regenerative therapy.
Yes, perfect.
Please go on.
Thank
you, madam.
All right. So we were talking about regenerating the endometrium by using endometrial mesenchymal stem cells. Obviously not going to have implantation because of this terrible endometrium. And again, recent studies telling us that subendometrial inoculation of mesenchymal cell produces a significant endometrial thickness. thickness, normalizes the endometrial pathology, immunohistochemistry, and the blood flows. So all of these PRP, GCSF, using stem cells, using mesenchymal stem cells, all of it significantly helps in improve outcomes in these patients. So now I've lost the arrow. Subbu? I can't see the arrow. Okay. If these patients, we have to resort to surrogacy. Obviously, if all these new things that we are trying, all of this fails, there is no option, then we have to go in for gestational surrogacy. And obviously that gives outcomes if the patient is able to produce eggs. Adoption, all of us will have to eventually resort to it if the patient has a uterus completely damaged, doesn't have any eggs in the ovary, which is completely damaged to severe tuberculosis. So we have to always keep these in mind when we are counseling our patients. Don't forget male factor. Remember, in the men, tuberculosis typically produces a cause of ejaculatory duct obstruction, and you'll get multiple blocks. So it is not amenable to surgery at all. And rather than epididymis, you have to do testicular sperm extraction in these patients. And very often through the testes, you have to extract sperms, then do a IMSI on these patients, and eventually be able to have them become a father. So very quick run through on the problems and complications. IVF, you will do. What happens then? Just look at a list of complications. Have landed up with miliary tuberculosis when they are really inactive tuberculosis, and you're going ahead and doing the IVF. Very rarely, abscess in the ovary has developed if the patient has a which you've missed. And this is a very, very long study of many 170 cases of congenital tuberculosis. The babies which are born in this actively infected mothers, very many premature babies, many infant deaths. And of course, when you treat them, the mortality is lower, but look at the problem. So congenital tuberculosis is a in an actively infected mother when she's pregnant. So we have to keep all of these things in mind. We have to realize learning and innovation go hand in hand. And the arrogance of success is to think that what you did yesterday will be sufficient for tomorrow. It will not be. Science is changing every single day. And so I'm going to end with just one or two things which the future maybe holds for us. And what is that? One important opportunity and challenge is latent tuberculosis. If you find latent tuberculosis, there is a possibility that we will be able to reduce the damage and we will be able to prevent this massive destruction which tuberculosis causes. And this will only happen if we get good diagnostic methods. So maybe interferon gamma release assays, which will accurately diagnose latent tuberculosis, and maybe better drug rifampicins rather than INH, which goes on for a long treatment course, will have better outcomes. So early diagnosis, early treatment is the only possibility for us. A very fantastic study, which is binding basic fibroblastic growth factor, which actually improves scarred endometrium in these women. So if the endometrium is scarred, we just give up. There's nothing you can do. But this fibroblast growth factor 2, the basic fibroblast growth factor, is the sustained release system of this, has been used for a long time for scars, for burn scars, etc. This is now being tried in scarred endometrium, and you can actually see patients' menstrual volume increasing, endometrium becoming thicker, blood flow to the endometrium improving. So this is a fantastic therapeutic approach using fibroblast growth factor. And of course, we are going to have a lot of focus, and it's already started, on the endometrial biome, the endometrial bacterial communities, which have an impact on pregnancy outcomes. Regenerative medicine, I've already spoken about using stem cells, bone marrow-derived stem cells for patients with terrible Asherman syndrome. And of course, maybe not too far away, we have a bioengineered artificial uterus coming up with the use of autologous stem recipients. We thought uterine transplant will become commonplace, but this study last reported successful 45 cases of uterine transplant worldwide, and cases with complete damage of uterus. This option, we have details of 45 cases with 9 live births already. This scientific data is available to us. So in the future, that is an option we can do. And not only uterus, ovarian transplant also is coming up in the future. And all of these are new studies. You can use auto transplant, where you can use your own cryopreserved tissue, which has been preserved earlier, or you can have an allo transplant, where you have a genetically different HLA matched donor. 70% of patients who underwent tissue transplantation had ovarian and endocrine function restoration. Follicular pregnancy was happening in 52% of patients. So ovarian transplant is also useful and an applied approach. So we have an amazing possibilities opening up for us in the future for all these patients whom we thought otherwise were completely dismal cases whom we could not help. So every day I realize that the more I live, the more I learn. And the more I learn, the more I realize, the less I know. We know very little, but every day there are amazing new discoveries which we can gradually apply to our patients. Thank you. Thank you very much.
Great presentation, Rishma madam. Nice to hear you, always such a warm person. But the main important point with the tubes and the endometrium of the tuberculosis, and it's a troublesome all over the, I think, in India. But what my question another rises nowadays, that the tuberculosis of genital tract should also be notified to the government. This is the latest thing which we should all do, and whatever treatment we are going to do for the tuberculosis, it should also be notified. So yeah, this is to just to eliminate tuberculosis from our country. So it's very, very important topic.
Very important, because that's the only way we'll get some data, some figures. There'll be some standardization, because now like treatment is, you know, like water, people are being treated for tuberculosis, you know. So yeah.
Yes, madam. So, are we doing question answer? Niranjan's few questions for madam over there in the chat box. I can see. Should I ask questions? So, one, it's not related to TB. Still, there are questions for madam. Are we doing it? So, one question is cystectomy for the endometriotic cyst. This is the one question. I think this is not related to TB. This question. Yeah, I think we should.
We are talking about uterine transplant and
I know
uterus and artificial ovaries. So we are trying to salvage and save everything. But having said that, yesterday I had a patient, 8-year-old with adenoma, and she's gone to 2 gynacs in Mumbai, and she's been advised hysterectomy. She's a single girl. So I was shocked. So when you say endometriosis and adenomyosis hysterectomy, I was aghast. But even today, this is.
I think there is no question related to TB over there. One more question is again endometrioma and all are there. Gonadotropin, which is better for IUI and FSH or HMG? This is the another question is over there.
I think there is absolutely no. That has now been established in many different studies that there is no significant difference between the FSH or HMG or recombinant or urinary or highly purified. All of them give similar outcomes, except in patients who are PCO, who have very LH. Then you may want to give them only FSH, pure FSH, rather than also additional LH. But other than that, all of them have similar outcomes. You can use whatever is convenient. I think cost is the major deciding factor.
Thank you so much, ma'am, for nice presentation, right from uterine transplantation to ovarian transplantation. Over to Niranjan. Thank you so much.
Thank you. Thank you.
Thank you so
much. Thank you, Dr. Rishma Pai, madam, for giving your valuable time on this Saturday weekend, and Dr. Kavita Bapat, for you also to join us from Indore. Wonderful presentations were done by you, and thank you, madam, for moderating this session. I would like to close this session now. Thank you for your valuable time, both of you. Now I call upon Dr. Parikshit Shah, Joint Treasurer of FOXY, and he is also the member of the Managing Committee of Mumbai Obstetrics and Gynecological Society. We know he was also the chairperson of Safe Motherhood Committee, FOXY, 2014 to 17. He is a consultant at Ashwini Maternity, and also he has endoscopy and assisted reproduction in his armamentarium. He is a consultant to the Jupiter Hospital, Thane. He has got many awards and publication. I'm handing over the mic to Dr. Parikshit Tang to introduce my teacher, Dr. Nozar Sheriar Sir and Krishna Kumar. Thank you.
Thank you, Dr. Chavan. I'm sorry, I'm attired a little differently than what I intended to be. I had to come away to the hospital. But in any attire, it's always a great pleasure to introduce Dr. Noza Sheriar. He's past Secretary General of FOXI, past President MOGS. He's a consultant to the who's who of Mumbai, really, at all the premier institutes of the city. And his biodata really would run into at least 15-20 minutes. I mean, if we are being quick and modest, But above all, what I would like to say is Dr. Sheriar is an inspirational figure to young gynecologists, to young practitioners, for simply the way he conducts himself. And having said that, I'll say no more, and I'll hand over the stage to Dr. Sheriar for the talk on hysteroscopic myomectomy. Welcome, sir.
Thank you, Parikshit. Thank you, Niranjan, for this opportunity of being part of a really amazing faculty that you've put together today. And thank you for giving me the chance to speak on hysteroscopy, which is a subject really special to me. Parikshit, really kind introduction. Trust me, I have the greatest admiration for the young people that we have who are going to be the leadership of FOXI, and we are terribly proud of you and all your contemporaries and colleagues. And it's just great knowing that our organizations are in safe hands. So when Niranjan asked me to speak on 2 subjects this week, I selected the 2 areas of hysteroscopy that are really special to me. The first was on Mullerian abnormalities. That was 2 days ago. And the second was on hysteroscopic myomectomy. This amazingly, great man, Victor Bonney, is probably the one who put fibroid center stage. As Theodore Munger said, the purpose is the eternal condition of success. And every day when we still operate and do myomectomies in every which way, we are still giving a kind of credit to the work that this great man had done. Now, I believe that hysteroscopy has become the gold standard for many conditions and procedures. There is no other way of dealing with intrauterine adhesions, a submucous myoma, or a Mullerian abnormality. And anything else would be a travesty. And today we talk about myomectomies, maybe some technical nuances and some practical pointers. Firstly, we know that depending upon the location of the myomas, we have their impact on reproduction, on menstruation, and on fertility. You can have a very large subserous myoma, which could do probably nothing. Intramural myomas, distorting cavities, could kind of compromise outcomes. But submucous myomas, we know, definitely reduce fertility, increase miscarriage rates, and are the most dramatic when it comes to causing menstrual disturbances. Now, the classification of myomas today has been rationalized, and we basically have 2 classifications. We have the FIGO classification, which basically has the submucous myoma, the other myomas, and the hybrid myomas. And today we are primarily going to talk about the SM, the submucosal 0, 1, and 2, which are pedunculated intracavitary, more than half within the cavity and less than half within the cavity. And of course, I will touch upon maybe one other type of myoma, that's O8, which is a cervical myoma. The ESG classification classifies it into 3 very simple types. 0 within the cavity, obviously pedunculated. Type 1, less than 50% myometrial extension, which means most of it is in the cavity, usually sessile. And type 2, where the bulk of it is within the wall with a minimal myometrial extension. When do myomas impact fertility? Well, we had this study by Fari way back in 1995, who showed that when you compared a normal uterus with a myomatous uterus, and a distorted cavity with a myomatous uterus, dramatically less implantation, lower pregnancy rates, more abortion rates, and lesser birth rates, which means these myomas within the cavity or distorting the cavity definitely need to be addressed. And this was a study of 106 ART cycles versus controls. And they showed that when you had a submucous myoma, your pregnancy rate and per transfer was dramatically less than with subserous and intramural myomas. Given this, we needed something to correct these myomas, which at one point in time required the uterus to be opened, bisected open, to take out these so-called submucous myomas. And I must give credit here to the pioneers, Dones, Vale, and particularly mention Hales, who gave us the continuous flow resectoscope, who showed very early, and this was the exciting times of the early 1990s, where they showed myomectomies dramatically improve pregnancy and delivery rates. So let's first start off with the very basic myoma, which probably for me is the most troublesome in terms of menstrual symptoms, and that is a FIGO SM0 or an ESGE type 1 myoma. Now here what you basically have is the myoma is completely in the cavity. It has a pedicle, and it's always so tempting to go and detach the pedicle. Now when we were students, Dr. Motasha had once told us how she'd done this for a case, and then you had a free-floating myoma, which you could do nothing about. Remember, once you dissect a myoma, and it's no longer connected to the uterus, electrosurgery will stop functioning. So this is a unipolar current. This is a resectoscope, which for me is definitely the best instrument to use. I know something like this could have been dealt with a hysteroscopic morcellator, which I haven't really used in practice. Could be an option, but I think this instrument works great. And the important thing is go and resect down the myoma to a reasonable size. And then finally, at the very end, when I feel that now there is enough for me that I can easily remove from the 1 centimeter dilated cervix because of the resectoscope, you can see here that was the attachment. The entire myoma is out, and you immediately have a normal uterine cavity. So let's look at some of the lessons from the masters. And the first lesson is not by force, but by skill. And that's exactly what you do when you're dealing with a myoma. And then we come to the FIGO SM1 and the ESGE type 1 myomas. And here, this is a patient in whom there was a reproductive wastage and secondary infertility. You always start off with mapping the myomas beforehand. And a transvaginal ultrasound is excellent, and a 3D ultrasound is even better to do this. Start off with the diagnostic hysteroscopy. Do not go in directly with the resectoscope so that you can plan what you're going to do. And here again, we had 3 myomas within the cavity, and you saw how I resected it down and finally took out the pedicle. And we had 3 other myomas that were there within the wall, largely within the wall, to which we turned our attention, like this one. Only a very small part of it was in the cavity. And then you need to work through a very small space. And as you do it, more and more of the myoma is extruded out of that small space. And that way, systematically, you start off with the posterior myoma first. You incise the overlying capsule. Gradually, the sessile myomas start coming more and more into the endometrial cavity. And before you realized it, you've gotten the entire myoma out. This patient went ahead and conceived easily on her own and had 2 successful pregnancies after the surgery. Now, sometimes we deal with large myomas, and here Tom Peters has said, under promise and over deliver. And do not be hesitant in telling a patient that you will require a multi-stage procedure. I will still tell them that when I'm dealing with a large myoma, usually the type 2 myomas. That we can do it in a single step procedure is going to be a bonus. And today, a majority of cases, of course, of type 0 myomas will be single step. Multiple stage may be required in type 2, but even here, you are able to usually succeed with a single stage procedure, even if it's an intramural myoma. How do you do this? Well, firstly, what you do is you open the dome of the myoma. Then you try and get the myoma to come into the cavity. People have used uterotonic agents. You can do what is called as a hydrostatic massage by turning on and off your fluid. You can take out your instrument and bimanually massage, and thereby you can bring the intramural part completely into the cavity of the uterus. And you just have to make sure that you've got enough outer myometrial layer to do something like that. So here is a FIGO SM2 or an ESG type 2, where you can see just a very, very small part of the myoma is bulging into the cavity. I would say in this case, barely about 30%. She's already been counseled about a multiple stage procedure. Be ready with an intraoperative ultrasound. And the first thing you've done is you've kind of opened up the dome of the myoma. Now you have to learn to recognize what the myoma tissue looks like and what the capsule of the myoma looks like. Unlike other myomectomies where you incise the capsule and then you kind of have the myoma coming out here, learn to recognize the capsule. The difference in hysteroscopy is we are operating from within the capsule, unlike other myomectomies, abdominal or laparoscopic, where we try and bring the fibroid out of the capsule. Now, if you can see here posteriorly, you will notice that you are gradually, after you find the capsule, staying within the capsule. Take your time. There is absolutely no hurry. You go bit by bit. Keep recognizing the myoma. Constantly be watchful of any kind of a fluid overload. So you have to avoid excessive pressures. I'll come to this a little later. If there is one complication of a myomectomy that I dread, it is that of fluid overload. Of all the hysteroscopic surgeries, this is the one surgery, because there are large feeder vessels there. I'm happy to see those vessels. Seeing those vessels basically tells me that the pressure gradient is towards the cavity and not towards the vasculature, which also tells me that I'm not losing a lot of fluid into circulation. You find the edge, you define the capsule, and by the time you finish, you can see that entire capsule there. A few tags of remaining myomas are removed. And what you think is a very, very large open area really closes down almost instantaneously when you let go of the pressure. As the uterine cavity goes back to its original size, this entire opening that you've created becomes a very, very small opening in the endometrial cavity. The cavity heals well. Very rarely have we seen any adhesions here. And that's how we can do this. Myoma, probably just put it next to a 20 cc syringe to show you how much tissue was removed at the myomectomy. And a lot of this tissue was intramural and done successfully. Samuel Jackson has said, clear your mind of Kant. And sometimes people, when it comes to a myoma which is in the wall, decide that this is too difficult, and they end up doing a laparoscopy where you not only have a serosal incision, but you've also opened up the cavity. Now, these are the slightly different myomas. This was a cervical fibroid we had a long time ago, and the entire fibroid was below the internal os of the cervix. Now, what this does, the principles remain the same. Only the space you have to work in is extremely limited. Always be ready to do intraoperative ultrasounds. I do not think laparoscopy really helps if done simultaneously, because I believe laparoscopies diagnose the complication after it's occurred. If you have a doubt, ultrasound probably has a bigger, better role to offer. You work in a limited operative field. As you incise, you can see the edge. We are constantly keeping an eye on the edge between the cervical tissue and the myoma. And these small little bites, and before you realize it, you've gotten the entire myoma out. It's pushed into the cavity. In fact, the same principle is followed by us when we do hysteroscopies for cervical ectopic pregnancies. We've already done 6 to date, and it's amazing how much work you can do in this limited space with endoscopes with a very, very successful and a complete outcome. So this is an entire myomectomy done. You can see that little cavity of the cervix, and the cervix is completely normal after that. So firstly, please understand that when you're doing any hysteroscopic surgery, there is no case in which you will not have the risk of complications. Of course, risk of complications is low. You could have hemorrhage, you could have perforation. My biggest fear is fluid overload or glycine toxicity. It's not how much you use. You could do this with a unipolar or a bipolar scope. I still prefer the unipolar. I feel it works better. I feel it cuts better. But with my friend Atul, use the bipolar as well. Great instrument. You can still have an overload with an electrolyte solution, but it's much safer than using a non-electrolyte solution like glycine. Watch the fluid deficit. Just 2 weeks ago, I did a large myoma. We used 21 liters of glycine, but we got back more than 20.5 liters. So as long as you know that there's no fluid deficit, you can continue with your work. What can you do to make it safer? Map the myoma. Make sure there's a myometrial mantle. If there is a doubt, stop the procedure. Avoid over distension. In hysteroscopy, beware of the beautiful white cavities. It looks great, it feels great, but that means your fluid is going the wrong way. Rollerball the base of the myoma. And we also have the option of using vasopressin. Some people have used it in the cervix, but we actually have a resectoscope mounted needle we had once upon a time, which can be used for this injection. Stay within the capsule. And if there is a doubt, stop, give a GnRH and go back for a second stage. Now, you have to have a very accurate deficit measurement. If you reach a 1 liter of deficit, be prepared to stop your procedure. Once you go past 1.5, no matter what you stop. Pressure bags, according to me, are necessary for diagnostic scopies. Endomat is a fabulous, fabulous tool to have for diagnostic and operative scopies. Having said that, having started with gravity and somewhere gone back to gravity, particularly when I'm dealing with a myoma, I find that if you can learn how to handle this well, the least fluid deficits I have are usually using gravity. And as I told you, the 21 liters that I had 2 weeks ago was with an endomat, because you're driving in fluid at large volumes. If there is a deficit, stop the procedure, monitor the patient, induce diuresis. Please be bold. Please give 100 milligrams of furosemide. Please deal with the severe hyponatremia by starting off with saline. Correct the hypokalemia, hypocalcemia. Put her in an ICU if required, and be assured that if you do well, you do your things well, hyponatremia of even down to 115 or less can be corrected very quickly. But if you don't, she is going to have all kinds of problems. Another complication that you always have to be worried about is a perforation. Now, this was a patient with multiple myomas, previous surgeries, who asked for a myomectomy and a TCRE. And you can see the myomas are all over the place. They are intramural. You are gradually going in. These were the posterior myomas first. Constantly maintain vision. One of the first principles of endoscopy is, if you're not seeing stuff, please worry. Don't put it off as, oh, my distension medium isn't fine. Oh, I think, no, you have a problem if you aren't seeing things. When you're constantly watching things here, resecting the wall here, came up with another myoma there on the right side higher up, and the procedure just went on, and we kind of kept getting, you can see more and more myomas popping into the cavity, and the surgery was really going well. That was another myoma which was intramural, which suddenly started coming into the cavity. And there we are, we're seeing the base, we are doing the TCR, the resection, we're seeing the myometrium. And then as we were doing the procedure going well, at one point in time, we suddenly felt that we weren't seeing things as well as we were seeing in the rest of the surgery, and we are bleeding. Now, something like this is a warning sign. Please know that you should know when to stop and quit. We were trying to look where it's coming from, moving the chips aside. There was a bleeder, and above that, you can see a little space and a defect. You still had distension because you still have distension fluid going in, but this was not as good as we had earlier on. And that probably was, or obviously was, the place where we had perforated. And that was the perforation. And luckily, we diagnosed it. We stitched up the perforation. We completed most of our procedure. by then. Thankfully, we had most of the myoma out. Well, actually, after finishing of the perforation, I did still went ahead and put in the Mirena because that's what I told her I would do. Patient's been following up for years since then, doing extremely well, is amenorrheic. But had we not made that diagnosis when we did and successfully repaired this, we would have had a completely different outcome using electrosurgery without realizing we had perforated. Myomectomy, definite role in infertility, but please understand that not every myoma causes infertility or subfertility. So ultrasound diagnosed submucous myomas, they had a study group and they had, which had hysteroscopic myomectomies, and the others just had a diagnostic hysteroscopy. And they found that after the myomectomy with no other treatment, the study group had a 63% pregnancy rate as compared to just about 30% with the group that was under observation. Well, for me, myomas are more of a problem when it comes to menstruation, menorrhagia and dysmenorrhea, particularly if they are submucous myomas. Most of these menstrual patterns improve almost 90% with the myomectomy, sometimes along with the TCRE. Reproductive problems, yes, infertility, but sometimes the myomas are blamed for a lot of infertility they don't cause, particularly if they are not distorting the cavity. And the patients who had infertility had viable pregnancies in 76%. So I'd like to share my very last lesson from the masters, and that's the great Hippocrates, who said, primum non nocere, first do no harm. Myomas, particularly if they are in the cavity of the uterus, particularly if they are submucous, have absolutely no modality that can be used to treat them. I believe every gynecologist has to become a hysteroscopist because there's so much we do in gynecology that can't be done any other way. I think most gynecologists can master a number of hysteroscopic procedures, even submucous myomas. But be prepared to admit your limitations. If it is a more difficult case, if it is an intramural myoma, and that's when you should seek the help of someone who can probably do more justice to your patient than you. Thank you very much.
That was absolutely masterful, sir. And it's always a pleasure to hear you on this subject of hysteroscopy, especially hysteroscopic myomectomy, which can be a fairly tricky and difficult procedure. And really, that was a brilliant exposition. Thank you, sir. Thank you so much. Now, I have the pleasure of introducing and inviting Dr. S. Krishna Kumar. And I will put on his CV so that I have a formal introduction of Dr. Krishna Kumar. He is the Chief Consultant at JK Women's Hospital and at Fortis, Kalyan. He is the President-elect IAGE 2020-21, Secretary General of ISAR 2018-20, and his center is recognized for ICOG fellowships in assisted reproduction and endoscopic surgery, and it's a FOXY recognized center. I have had very pleasant interactions with Dr. Krishna Kumar, a very forthright man, a very simple man who does not hesitate to speak his mind. And I invite Dr. Krishna Kumar to please begin his talk.
Thank you, Parikshit, for the kind words and kind introduction. And thanks once again to Niranjan. This is the third lecture for him I am giving today. Not the week, but today. And of course, Nozer was fantastic in his talk on the myomectomy. And yes, quite a few of my thoughts he has already given to you all. But as you know, as he rightly said, today no gynecologist can remain not doing hysteroscopy and not knowing hysteroscopy. And we all should be doing hysteroscopy for all our patients, for the benefit of the women of our country in general, but to have complication in hysteroscopic procedure, just the one which he showed, that was at the end of the procedure, but you can have it at the very beginning. Just it's a catastrophe if you have some of those complications which we have heard in the past of morbidity and mortality. So today, my talk is going to be how to minimize them And definitely, as he said, you can master most of the procedure if you remain within those limits and you accept your own potential or your own capacity to deal with them. In general, if you see, the complication reported is quite less, but catastrophic consequences like glycine overload leading to death and blindness have been reported in the past, and that is where it has been proved that safety and outcome has been linked to adequate training and adherence to safety recommendations. If you are not well trained and you don't adhere to those basics, you can have one of these complications. Of course, I will concentrate more on the perforation of fluid overload. Yes, dealt with quite a lot. Air embolism. These are some of the most dreaded complications, common ones, apart from the others mentioned. So this is very common, was very common the days when we were not, or rather we were going ahead with the dilatation. And dilatation, we know that we have had so many false passages, perforation. And this is one of those earlier days when we used to perpetually dilate and put in that 7 or 9 millimeter sheet to see the uterine cavity. And there you can see a false passage created by one of my fellows, and then the normal cavity. The moment you don't see any ostia, you have to imagine that you are not within the uterine cavity. So that's how you trace it. And you can see that if you're not perforated, you're able to really tackle the problem. But on the other side, you see a little over enthusiasm, not looking at the anatomy, not taking that precaution. You go on cutting at one point, you can still perforate with a Caesar. So that is where your over enthusiasm or sometimes ignorance, both can lead you to complications. Now, RCOG study, I was really surprised. They said 55% of the perforation in their study when they did for all the RCOG members was entry related, and it was basically secondary to simple procedures like sounding, dilatation at the insertion of the hysteroscope. And of course, 45% were technique related when improper technique was employed. And this reason for perforation was mainly attributed to improper knowledge of anatomy. That is something alarming. And that too, the doctors or the consultants who were doing very religious per vaginal examination had the least chance of perforation. And definitely, if you have an improper idea of fluid management, and what it concluded also was no teaching program includes the safety at entry and understanding the anatomy and instrumentation. So that's a really tragic scene when we are going for advanced surgeries, but we do not care about the basic anatomy and the fluid dynamics when we are doing hysteroscopy, which is all about anatomy and physiology. We know that the fundus is just about 1.5 centimeter. The uterine cavity is max about 3 to 4 centimeter. In a nulli gravid, lateral wall is just 7 millimeter or 9 millimeter. The ostia, the thinnest, 4 millimeter. And with distension, their thickness can be reduced by 30 to 50%, and more so if you are dealing a postmenopausal uterus, which is already flaccid. So you have to know that you're going to work in a very narrow cavity and your margin of error is quite limited. So you have to be extremely cautious, very slow in your movement, not unlike the laparoscopy. But today, with the advances in the instrumentation, we have all sorts of smaller diameter hysteroscope. And luckily, even the resectoscope has greatly reduced in size. And today we have up to 14 and 16 French, which is hardly 5 or 6 millimeter. So that is a big deal, and quite a lot of patients where your dilatation is going to be a big issue, where you do not want, especially in the reproductive age group, or we get these days a lot of patients beyond 70s, close to 80s, even 80s and beyond. So their dilatation is a big, big dilemma. And all-in-one sheets which are available, right from 3.7 millimeter to 5 millimeter, has made our life absolutely easy. And changing instrumentation, today my trolley is not as clustered as it used to be those days, where we have just the sheet with a Caesar and a grasper and an inflow sheet or a suction tubing. That is all. And today, energy in hysteroscopy is relatively boiled down to Caesars most of the time. Resectoscope using monopolar or bipolar has been restricted to most of the time myomectomy and very large vascular septum. Otherwise, even there, I would also be very bold enough to say that I believe more in bipolar because of the safety margins which it gives. Definitely, the speed or the power was a big question, but today with some of the beautiful generators, we can finish in the same speed as monopolar. But today, fortunately, hysteroscopic surgery, only 20% require resectoscope. Majority can be done by that operative simple sheath with a 2 millimeter or a 5 French scissors majority of the time. Occasionally, those electrodes, which can also be 2 millimeter, but with the availability of those 14 and 16 French resectoscope, really even resectoscopic surgery has become much more simple. Now, if I have to just inform you, the distension actually required intrauterine to visualize the cavity is supposed to be between 45 to 55. And at 70 millimeter, the ostia opens up and the fluid starts going into the abdominal cavity, and the volume flow per minute which you need to maintain is just about 50 ml per diagnostic procedure per minute. And in operative procedure, you may go up to 150 to 200 milliliter per minute. And of course, the fluid deficit, the all important, in myomectomy especially, you should actually measure the even up to the last drop. So the distension media, I definitely would say that saline and ringer lactate scores over glycine for the simple reason that it not only just is electrolyte content, whereas glycine is absolutely electrolyte free. So any deficit of even 1 liter is going to cause an hyponatremia. And more so, the osmolality, which is so very important in normal human physiology, is much less than what blood is. 200 milliosmol per liter, and what is blood is close to 275, where saline and ringer lactate match it to the greatest extent. So that is where the fluid overload, even if it is there, it is much easily manageable. And today, very clear picture is there that the distension media safety, saline and ringer lactate, and nothing more for operative procedure. Now, when you consider the mechanism of irrigation of fluid absorption, it is said that even when you are working in that 40-45, 10 to 30 ml of per minute of fluid is getting into the system because of the opening up of the sinuses, but lower the osmolality of the irrigating fluid compared with the blood, the irrigating media enters the cells very quickly. That is because of the osmolality. So in general, we have pulmonary edema because of fluid overload, but specific to glycine, I don't have to tell you, the list is enormous. Hyponatremia, transient hypertension, followed by hypotension, disorientation, temporary blindness, increased ammonia levels, encephalopathy, and death. So definitely, glycine should be moved out of the operation theater, I feel, for this simple complication, because if you are not very diligent in using it, and the negligence will cause a lot of hiccups for you. And you can see the glycine enters the cells by virtue of osmosis and develops cellular edema, and a fluid overload of even 1 liter decreases the electrolyte sodium by 10 nmol, and elimination of glycine occurs primarily by liver, leading to ammonia, and it's an inhibitory transmitter in the retina, and definitely can cause transmission from the retina to the cerebral cortex to be hampered and causing temporary blindness. So imagine a patient, even 48 hours of blindness after your procedure will just not leave. So whether all these fancy pumps are available, they are good as far as the safety margin is concerned. There are a lot of other pumps, and then the newer pumps which has come from one company where it gives you an alarm that once you are increasing above 60, it gives you an alarm. So it claims that it can record the intrauterine pressure much better than none of the other machines which have, and it has different settings for different procedure, right from the 4 millimeter sheath to the 9 millimeter resectoscope. It has different settings. More so, the flow rate is maintained, and the pressure which shows during the procedure 45 and 50 ml per minute. And in case you are doing an operative procedure, it goes a little high. But if in case you are unable to have, I would recommend that you should go ahead with buying this 2 Medex bag with a TOG set, where you can have a continuous flow without even air entering into the tube at any time. So one bottle gets empty, the other is ready to go. So you should have a Medex bag with a TOG set, and we have done it almost 10 years before I could buy one of these fancy pumps. So definitely distension media pumps are something which you have to take care, and definitely a distension, somebody observing the fluid deficit, and as already shared by Dr. Nozer, the moment you have more than 1 liter glycine deficit, you should speed up your procedure and stop at 1.5 liters, send the blood for serum electrolytes. But just normal saline or ringer lactate doesn't mean you won't have complication, though pulmonary edema can still occur. AGL guidelines say that you can have a deficit up to 2.5 liters. The safety margin is definitely more, but I stop at 1.5 liter even with normal saline, because that's always a possibility that some amount of pulmonary edema does set in. Of course, all the measures of, once you have a fluid overload is already mentioned in detail, but before embarking upon any procedure to minimize the complication, it is needless that you yourself should have taken a proper history and all the imaging. If you could have done it yourself, at least see the pictures whichever is there, and do always any procedure in the immediate postmenstrual phase and keep the instrumentation ready. So once you know what you're going to, your trolley should have everything, rather than waiting for the OT boys to get it, and by the time you waste time, you have a lot of fluid loss and you get restless. And this imaging system today by sonography most of the time solves your problem in identifying all uterine anomalies, all macroscopic uterine anomalies, right from the congenital one to the fibroid and adenomyoma. So all this good imaging has made our job easy, but what you need to understand is the true anatomy of hysteroscopy. True anatomy is not the uterine cavity and the spindle wall. You should be able to identify right from the external os, follow those mucosal folds. Just no need of blind dilatation. You just follow those mucosal folds with your hysteroscopic sheet. Never ever even try to hold the valsalum or dilate the cervix. Enter under vision. Use the smaller diameter 4 or 5 millimeter, and you can have a beautiful virgin view of all the tract, and you can see beautifully the oval shape of the internal os. And this is just a 40-second procedure. You can have absolutely virgin view, no blood, no debris. So that is where avoid dilatation. So even if you're used to putting in a speculum and holding with a valsalum, I would recommend this: do not dilate. Take your sheet, pass it directly. The fluid will show you the way, and under vision you can do. For the initial beginners, non-touch technique may not be the right one. You can hold it with a valsalum, but don't dilate, and always enter under vision. So your false passage and perforation will all be a thing of the past. So that is first step in minimizing the complication. And in case you have some such uterus where a 70-year-old with postmenopausal absolutely tight external os, even here I would not dare to hold it with a valsalum or Ehlers forceps to just get a grip, because most of the time this cervixes never come under your control. They always keep slipping. And dilator, if you put, it's a real nightmare, because it is going to slip and really going to fly all over the place. So what I recommend is just take that grasper in hand, just dilate it mechanically. The 2 millimeter becomes 3 or 4 millimeter, and you can see the passage into the canal. And of course, since it's a postmenopausal, there is going to be further atrophy of the cervical mucosal glands. Even the internal os is never identifiable in many of these cases. But you can identify by following those mucosal folds. They will all lead you to that particular internal os, which is the true internal os. And you can just gradually take the help of the fluid along with a little bit of pressure and little bit of manipulation, occasionally scissors to cut off those fibers at the internal os. You can enter. So absolutely no need of panicking. Perforation will never occur, and you find such multiple polyps, all looking benign, plethora of polyps. So this is where under vision, absolutely entry will save you so many problems, and more so, it doesn't cause any bleeding. So your main debris, so you don't have to waste your time, sucking out that intrauterine fluid before you can start the procedure. But before you embark upon some of this procedure, these are some of the simple procedures like removing a foreign body. Under vision, you have entered, you can locate it. So this is one simple procedure where complications are going to be less. So any beginner in hysteroscopic surgery today should get something like a lost IUD or any foreign body, you can definitely be at ease because you're not using any energy and you're not going to definitely cause any complication. This was actually a bicoordinate uterus. Somebody brought from her operation theater because they could not locate the copper T in the blind DNC. So this was a septum in between the two horns and the copper T was to one side. And definitely hysteroscopy is the answer. Here you can start seeing the copper T in the other horn. And here this is, and you can see, appreciate that this is a fairly old insertion, maybe at least 8 or 10 years, where the lady has been happily living with it and holding such with a good grasper. But many a time the limbs or the arms are buried in the endometrium and to some extent even burrows into the myometrium. So removing it is a little trick. You cannot just pull it because the grasper will never allow you to have a good grasp and just pull it like that. So you need to be very careful. You need a good alligator grasper or this. You need to dislodge it, push it up towards the cavity, dislodge it totally from the myometrium and then pull it out. So this is as simple as it is. Start off with these simple this, and of course polyps so very common even in infertile group or reproductive age group, very easy to remove. So polyp, if you find during your hysteroscopy, of course the specificity of the diagnostic value of hysteroscopy is much more than sonography. Here again, this is one of the simple procedures which most of you can master even at a very early stage. Of course, again, if you can go to the base, I would still not use energy or a resectoscope for the simple reason that dilatation will be required unless you have the smaller diameter resectoscope. So doing with Caesar and remaining within the proper anatomy, you're not going to do any harm. So removing this polyp is very simple with the scissors, and especially if the patient is of a reproductive age group and is for further fertility treatment, avoiding energy may be a little more sense because you can damage a little bit of the other part of the endometrium. And learning to do the scissors might be of great help in most of the cases because reproductive age group hysteroscopic procedures are common. And here you can see that you can pull it out with those fan graspers. Now, even as I said, today 80% of the surgery I believe in doing with only scissors, and even a large septum, a complete septum, we would recommend that go ahead and do with the scissors only. This is one side of the cavity. You can see the septum right from the internal law. So again, start in the midline. The scissor blade should be horizontal. It is just a 5 French or 2 millimeter. Can I have somebody muted? Yeah, thank you. So this is just thing. Again, bleeding is never a problem. Of course, a little over distension helps you to have the separation, but you can remain in the midline and the blade should always be pointing towards the ostia. That will make sure that you are in the right plane, and unless the brace is very broad or vascular occasionally, where you have to really use the energy, 90% of the time, such large septums also can be dealt with scissors itself. Again, because we want to avoid energy, we do know the endometrium has to grow on this surface, but all the time the blade has to be pointing towards the ostia and never go on the same side. Alternately, look at the ostia both the side and remain in the correct plane in the midline and equidistant from both the ostia on both the side, and you will never repent even for using the scissors. The advantage of scissors, and if you can complete it, that you, even if by chance you do perforate, the chances of thermal damage or any other damage is totally negated, and that is the advantage. Now, if at all, of course, where this is a complete septum, where you can see a complete rather vaginal septum also and 2 cervices, a lady who had 2 abortions, and you can definitely enter even here without any support from the valsalum or the speculum. You can see the end-on view typically seen in patients where you look like an unicornate uterus, where you see the ostia which is straight around 11 or 12 o'clock. Ideally, the ostia is usually at 3 or 9. but this is how you diagnose, and this is the other side you can enter, and you see that the septum is there completely. And this cutting these septum is always a little debate whether to cut with the scissors right from the cervix, or I generally go with a resectoscope in these cases and perforate it just above the internal os, because that is the thinnest part of the uterine cavity. So this technique, of course, I do not put any other catheter or anything in the other side, but when I'm doing from the right side, my knife, Pauline's knife, is pointing towards the left cavity. If I'm doing from the left cavity, here you can see I've already cut part of the cervix there, cervical septum there, and you can still cut it. And then the rest of the septum is like a routine septum where you have already seen the other half of the cavity, and you can just use it the same way, the same principle like what we did in Caesar. So this is one way of cutting a complete vaginal or a uterine septum. Here again, the beauty is the trick is do small bursts, don't be in a hurry, and always stay 5 millimeter away from the ostia. And even if you undercut, the present literature, especially the fertility sterility, does say that remnant of 0.5 to 1 centimeter septum, redundant septum, doesn't cause much harm in such large septum. So you don't have to bother if some small area. So it's always good idea to undercut rather than creating an umbrella inside the uterine cavity. Now, submucous myoma, Dr. Nozer has already elaborated, but I wouldn't want to show much. This is just, of course, one of those myomas which is always a little difficult. The Lasmar classification I take upon more, where the length of the spread onto the wall also is taken into account, and more on the lateral wall, it gives 1 score. So anything above 7, it advises not to be done by hysteroscopy because the complications can be more. 5 to 7, it's a complex procedure, and definitely you need to be very versatile in moving your resectoscope inside the uterine cavity. The identification of the capsule and other things he has already explained, so I wouldn't take much time, but one such fibroid which is there right from posterior wall, lateral wall and anterior wall is always a little more difficult, but hysteroscopic surgery is one surgery where in case you think you are unable to do it in one setting with a fluid deficit, the advantage is you can have another day. You can always stop it at any time, but identification of the capsule and the normal myometrium, Nozer fantastically explained how to be within the right plane, identifying the capsule and removing it in complete toto is important, especially if the patient is not only menorrhagic but also for infertility. But damaging the endometrium is always a big no if your patient is for fertility treatment, and keeping those debris inside the cavity is always more better, because the moment you remove the resectoscope often outside, what happens is the blood starts coming inside and you spend more time in clearing of those blood inside the uterine cavity. So I somehow, of course it's a little trick and you have to learn by experience how to continue working in spite of the so many pieces of fibroid, try to push it to the other corner, and then if you do it at one sitting, always you will not only be much faster, the fluid used is also much less, and the complication is also definitely much less, because constant removing of the resectoscope also has a chance of air embolism. So that is something very common, a very dreaded complication in hysteroscopy, because the os is dilated and the vascular channels are already open. So the air can gush in, and definitely sudden collapse of the patient is a possibility. So in these cases also you have to remain sure that you're doing it in one sitting without much breakage. And I use these drapes, which are something like a simple obstetric bag, to collect the fluid up to the last, because we cannot afford the very fancy fluid management system. But though we do connect a part into the bottle, the rest which flows out of the vulva and the vagina or into the perineum, we do not put any cloth, because it's always extremely difficult to measure the quantity. This obsti bag collects up to the last drop and you can have a proper calculation. But once the fluid overload is there already as said by Dr. Sheriar, stop the procedure, send up sodium. Now a debate, because there is a plethora of morcellators which are available. but studies have proven that these morcellators are excellent for polyps and definitely for type O submucous myoma and some type 1. Definitely they are faster than and easier to learn than the traditional resectoscopy because of the advantage that not only do they cut, but they evacuate or suck the debris immediately. But the cost is a major factor, and the studies very clearly say that the acceptance of morcellator has been very slow. Probably we have a lot of experience using the resectoscope, and with due care, we do believe that it is much more rather financially compatible in a country like ours. But definitely, even otherwise, it is said that maybe only patients where the fertility aspect is more, they say that this is better. But still, studies haven't been able to prove that type 2 myomas, you just cannot use it and you have to go for resectoscope. And either of them is not been proved to be better than the others. So this is, I think, one more view of the same. Yeah, this is just a recent morcellation by the morcellator only, where of course the advantage is even large polyps and fibroid, you can continue to resect and not bother about damage to the endometrium and heat which is generated. So this is something which is coming up, but then our experience in these is quite limited. But a lot of papers do claim that for reproductive return, this has been much better than the energy, but maybe that's just a company-driven marketing right now. Now, intrauterine adhesions, again a procedure where only rather more versatile in hysteroscopic procedure, but today to tell you that if we thought that DNCs are reducing, we have started reducing the number of MTPs, actual reported cases are increasing because of the widespread use of intrauterine surgery by hysteroscopy. Myomas can cause up to even 32%, and a multiple myoma incidence reported by Asherman's is almost 45%. Septum can also lead to 7% of adhesion. This has appeared in the JMIG 2018. So definitely, since it's an iatrogenic disease, since we have caused it, we should be able to pick it up early. Why should Asherman become severe? That's always my question. Since after a procedure, patients present with oligomenorrhea or there is recurrent pregnancy loss, rather than doing some of those fancy blood tests, including all thrombophilias and APLA, simple hysteroscopy, either if you're comfortable without anesthesia, go ahead, or with anesthesia, definitely will show you that early adhesions are much easier to cut. The rest of the endometrium are very easily identifiable. And once this anatomy is seen, though there are a lot of pseudo-ostia seen, but if you can identify the true ostia, any procedure intrauterine is much, much simpler rather than when you do not see the ostia. So such adhesions can be very, very fruitful for the patient and for the surgeon because
5 minutes, sir. 5 minutes.
Doing it is very simple, and it is always patient will thank because the patient is going to be benefited definitely because our implantation potential is going to be as close to a very normal patient. So this is where Asherman is something like we smell ectopic and early ectopic, you can save so many things. Similarly, one should be able to smell Asherman because we have created it and we should be. But if a delay is there, this is what you will get. Right from internal os, the door is closed. You will not be able to enter into this. If you just do a blind dilatation, you create a false passage and you wonder where you are. So I again believe that without any dilatation, under normal smaller diameter hysteroscopic sheet, you can identify that this is the definite internal os because all the mucosal folds is leading there. All these sides from the cervical canal. So your simple Caesar will do the trick. Just dig it in, occasionally open it up, make it 2 millimeter and gradually occasionally nip those small adhesions. Of course, adhesions at the internal os are always more fibrous, more dense because that is the thickest part of the uterine cavity or the passage. But you have to spend time, you have to be a little patient. The 2 millimeter scissors will give you way, and occasionally just open up this scissors blade and you will see that you can finally cut those small fibers and start entering further. So this is one simple trick, that be patient, follow those mucosal folds, internal os, even if it is not allowing you, you can under vision, open it and then gradually push your hysteroscope into the opening which you have already done. So making 4 millimeter into 5 millimeter is not that difficult. And once you enter, you see more adhesions, more tubular cavity, because there is bilateral wall adhesions. This is the tubular cavity. So there is lower half of the cavity is still adherent. So this is where adhesions are still there. You need to do something like a lateral metroplasty here again. Refrain from using resectoscope. Your scissors will do. Make it little bigger and the 5 millimeter sheet enters and that is already dilated and you see the ostia and there are fundal adhesions. So definitely there is a delay in diagnosis, delay in treatment, but at least the cavity shape is quite okay. Though 40% of the endometrium looks a little unhealthy, these are again fundal adhesions. You can make the difference between fundal adhesions and septum. And cutting this is also a very simple thing. Now, re-adhesion prevention strategies are very important. In patients with Asherman, especially severe, you need to have some strategy to prevent re-adhesion because the uterine wall is always, close to each other. So the most recent evidence says that there is a level A evidence that either intrauterine balloon stent or pediatric Foley's catheter is the best. Of course, balloon scores over pediatric Foley catheter because it can occupy the corners of the uterine cavity, whereas this remains more or less in the center and the periphery on both the side, about 10 or 20%, may still get adherent.
2 minutes, sir. 2 minutes, sir. Thank you.
This is the Gubini mini resectoscope, the gentle side of resectoscopy. Smaller resectoscope has made our life much easy. As you can see, some of those postmenopausal polyps and patients who come where dilatation is such a big problem again, if you have to use a resectoscope, even this can be entered without dilatation. That's the beauty, where you avoid dilatation, you avoid so many problems, and you can enter with these even without dilatation. So this is a 16 French Gubini resectoscope. So that's where when we have a lot of these postmenopausal patients with so many problems at 70s and 80s, you see a large polyp. I wouldn't want to show this video full, just want to show that entry is again without dilatation, even with a resectoscope when you're using the smaller diameter resectoscope. So this is again a giant polyp. I think this was a very large polyp, almost you can see occupying the whole cavity. It was measuring 6 centimeters by ultrasound in a postmenopausal 70-year-old lady. So doing this is definitely not that difficult. Though, of course, resectoscope and energy should be used. We will T-shaped or lateral metroplasty. Again, I think I'm running short of time. Which one? But you have to diagnose it properly before you want to see the imaging, which gives you such a narrow canal. And then after the procedure, you get a widened canal. So that is where you can see how the scissors are to be used in office hysteroscopy, to T-shaped cavity also. You can just fix the 6th blade and go ahead and cut with the moving blade. So that is now adenomyoma. Again, if it is very close to the uterine cavity, you can just take the resectoscope loop and I will just run it fast and you can see the adenomyoma bulge. You have to be very careful, but this looks little dreadful at times when you think that they have entered the colon, because you can see the large crater-like hole there. There you can see, you just resect it and you can see the adenomyoma fluid coming out. But there was a scare whether we have opened up the colon, but then definitely there is no fluid distension loss. It was adenomyoma cavity. Open it up, cauterize the surface, and you can straight away. Now, of course, we have moved from OR to the office for many a procedure where because of the smaller diameter of instrumentation, but you need to have a dedicated room. You can't do it in your OPD in front of other patients. And definitely, hysteroscopy is evolving and it is mandatory that we all rekindle our expertise for the benefit of our patients. They deserve nothing less. So even a resectoscope, Gubini, we use it without anesthesia in a patient, though this was just during the corona time and we have not done any anesthesia. The patient is wide awake, and even a Gubini resectoscope can be passed without much pain, and you can cut off a polyp very easily. That is where I think we all have to evolve and progress further and really do the best for our patients. And I thank once again for a very patient hearing. So change to miniature hysteroscope, use less of resectoscopic surgery, more hysteroscopic surgery, and bipolar over monopolar is what I would still recommend. Thank you.
Thank you. Wonderful lecture, sir. You're an encyclopedia on hysteroscopy. That's what I can say. And it is great to hear from you. There are amazing videos which you have shown. Parikshit, are you there?
Doctors, I need a minute to give an update. I request to all viewers to please download the participation certificate by clicking on the link as shown in this slide. Thank you very much.
Yeah. Thank you, Science Integra. Dr. Parikshit. I think Dr. Parikshit has left us. Probably he is busy. Or is he there?
Yes, sir.
Yeah. Thank you, Dr. Krishna Kumar. Thank you, Dr. Nauzar Shariar. It was a wonderful presentation. You both are an encyclopedia and you accepted the invitation just few days back. I'm really lucky to have you as my teachers. And it's great to hear from you, Dr. Nauzar Shariar. I get a lot of comments about Nauzar sir, about his quotes and his presentations. So it's really nice, sir. We just met that day when we were visiting East India, and it was a pleasure to have you. A lot of comments, and I'm sure today night also I'm going to get a lot of comments. And we have Dr. Prakash Trivedi sir here joining, and Dr. Krishna Kumar Sarita is already there. So thank you, sir. There are no questions right now for both of you. You have done a wonderful job. And I would now request Dr. Sarita Bhalerao, my colleague from Mumbai.
Thank you, Dr. Chavan, for the opportunity
Yeah,
to
Parikshit has
part in
come.
your
Yeah,
program,
please.
and all the best to you.
Yeah, thank you, Parikshit. I was just doing your job for that time. And thank you for moderating that wonderful program. Now I hand over the mic to Dr. Sarita Bhalerao, my colleague from MOGS. It's my pleasure to introduce her. She's the Vice President of Mumbai Obstetrics and Gynecological Society, member of the ICOG Governing Council 2018-2020, chairperson AICC RCOG West Zone. She is attached to Bridge Candy Reliance Saifi Bhatia and also is attached as a clinical associate to Wadia Maternity Hospital. She is immediate past president of the Association of Medical Women's in India, Mumbai branch, joint secretary to Dr. Rishma Pai Madam, the president of Foxy in the year 2017, and she also was the chairperson of Foxy Quiz Committee 2009-2011. Welcome Dr. Sarita Bhalerao to moderate this session.
Thank you, Niranjan, for that kind introduction and for inviting me to participate in this program. And it gives me great pleasure to introduce our speaker, the dynamic lady from Pune, Dr. Sunita Tandulwadkar. She's currently the president of IGE. She's a skilled endoscopic surgeon. She's an IVF consultant. She's been the past vice president of Foxy. And I had the good fortune of working with her when I was secretary and she was the vice president. And I really know how her enthusiasm and her motivation knows no bounds. She also heads the Department of Obstetrics and Gynecology at the Ruby Hall Clinic, Pune, and she's been the Foxy Infertility Committee chairperson. She's the advisor and reviewer of the Journal of Human Reproductive Sciences and has received many national and international awards and published many books and contributed chapters. Over to you, Dr. Tandulwadkar. Looking forward to hear your talk.
Sarita, thank you for that wonderful introduction. Dr. Sunita just has messaged me that she has a sudden emergency of central placenta previa. She had come home, but she left for a Ruby Hall clinic. I pray that the patient is fine and she will be joining after the surgery. So we move on to the next presenter. Dr. PG Pauls is also having some issue in his Kerala, Kochi. So he has been kind and gracious enough to pass on his lecture of tubal canalization and tubal surgeries for infertility to Dr. George Paul, and I request you to please invite him. Thank you.
So I'd like to invite Dr. George Paul, who's a consultant endoscopic surgeon at Paul's Hospital in Kochi. He's the scientific coordinator of Cochin Gynecological Endoscopic Training Center, and he's done his ESGE Bachelor in Endoscopy from the European Academy in Belgium. And he's invited and done many presentations at national conferences and co-authored 11 publications in international journals and 2 book chapters. Over to you, Dr. George Paul.
Madam. Let me just share the screen. Yes. So first of all, I would like to thank all the organizers and especially Dr. Niranjan Chavan for giving me this opportunity. Unfortunately, my father couldn't be here at this point. He is a bit occupied with another event at the house. So today my topic is tubal procedures in infertility. So basically in the last maybe 1 or 2 decades, with the advent of ART procedures, tubal surgeries as such has taken a step back in endoscopy. So this is something that my dad and like all of us who does tubal surgeries would like to promote and show the importance of tubal surgery as such. So as you all know, about 30 to 35% of infertility is usually due to tubal factors. And studies have shown that if you do surgeries, tubal surgeries of various techniques, as I'm going to explain, these will give you a very good outcome on the right patients. It's all about doing the right patient selection. You can't just do it on every surgery that you are going to end up with. So tubal obstruction or tubal pathology is usually divided into proximal or distal tubal pathologies. Proximal ones, the causes are usually due to conjunctival spasm or salpingitis, endometriosis, mucus plugs, or various amorphous material. So one of the most simple procedure when it comes to proximal tubal occlusion is tubal cannulation. Studies have shown that in case of bilateral tubal occlusion, with cannulation, about 85% of the patients have relief, and out of that, about 50% patients do conceive spontaneously. And they give an overall clinical pregnancy rate of about 27%. So coming to the procedure as such, so it basically involves, we do both a observational hysteroscopy, like a survey of the hysteroscopy, and a laparoscopy before we go ahead with the actual procedure as such to rule out various other pathologies. And this basically involves the outer catheter. What we use here is a Novis catheter. What you're seeing, the transparent one, is the outer catheter. And you are using a guide wire. What we are using here is a Termo guide wire. So our point is to first identify the conva as such properly, and then point your catheter towards a conva. The guide wire is usually slightly curved, so it will be easier for you to curve it towards the conva. Once you identify, pass the guide wire, but make sure you're not giving an excessive pressure. Make sure you're not causing trauma to the tube or the endometrium as such. In this procedure, we pass the catheter almost towards the end of the fimbria, which is not required when you're doing a normal case of cannulation. This is just for academic purpose. I demonstrated that passing the catheter almost to the tube fimbrial end. You can see spill from both the sides here following the cannulation. So normally if tubal cannulation fails, usually majority of the cause is usually due to salpingitis or some sort of obliterative fibrosis. And in such a case, our next option is only ART. Now, when it comes to distal tubal pathologies, it's mostly due to PID or endometriosis. Here, the major factors which affect the success of a tubal surgery is usually age. Younger the age, better ovarian reserve. If the prior fertility is good, that is also a good prognosis. The site and extent of the tubal disease, the presence of any other infertility factors, and the experience of the surgeon really do counts here. So that is something that has to be kept in mind. This is something which has a very steep learning curve, unlike your ART techniques. So when it comes, another simple procedure here is salping ovariolysis or your adhesiolysis of the tubes. Basically, our objective here is to restore the anatomy of the tubes and the ovary. So it's shown a good success rate of about 40% of pregnancy rate in cases where it's the adhesions are usually limited to filmy adnexal adhesions. If it's just a mildly dilated tubes with thin pliable walls and tubes with lush endosalpinx and preservation of good mucosal folds. So in such cases, doing a salping ovariolysis really gives you a good outcome. So for this, I've selected a very simple case here. Actually, the anatomy is not too much distorted here, but then I chose it so that it can be easily shown or explained to the beginners here. So here you can use scissors or even any sort of energy source. Here what we're using is a bipolar shearer here. Our objective is to hold the fallopian tube using an atraumatic grasper and cut the adhesions or release the adhesions using scissors or minimal energy source. So normally the distortion in the anatomy affects the ovum pickup from the ovary for the tube. So our objective is to restore the anatomy. You can see both the sides we have restored the anatomy here, and this was a case of ovarian drilling as well. So the next, another procedure would be neosalpingostomy. It's quite simple procedure, as you all know. It's basically just an opening of the hydrosalpinx for mild hydrosalpinxes as such. And it's shown a good percentage of intrauterine pregnancy for about 58 to 77%. But then still there are small chances of ectopic pregnancy here. Another simple procedure is fimbrioplasty. It's simply opening the fimbrial phimosis here. Basically, you open it up and then secure the opening to the tubal serosa with sutures or electrocautery. So this, so normally we don't encounter much of cases for salpingostomy or fimbrioplasty. So this is a video that I got from the internet. We haven't done anything recently here. So our objective is to first do a chromoperturbation, identify the site of the blockage. As you do the chromoperturbation, you can see the tube filling up. Once you identify the point, use the scissors to open up the blockage and then widen the opening and make sure you have a good flow of the dye and make sure it's a patent opening here. And you can suture the edges to keep it so that it stays patent. So when it comes to salpingectomy, you might be thinking that it's not a fertility enhancing or it's something in the opposite direction. But then in cases where there's a very poor prognosis for the various tubal surgeries that I mentioned earlier, such as patients with dense peritubal adhesions or with massively dilated tubes, thick fibrotic walls, ones with very sparse luminal mucosa. In such cases, salpingectomy is a good option, especially when you're planning for ART procedures such as IVF or HC. And studies have actually shown that there have been cases of spontaneous pregnancies following unilateral salpingectomy for unilateral hydrosalpinx. So although it sounds funny, but then that does happen at times. So the next procedure is tubal anastomosis. It's something which was quite a thing back when it started out. But with at the advent of ART, the need or the indication for tubal reanastomosis has really come down. But then there are still patients that would want to have a normal conception, who are very adamant that they won't undergo a IVF, or there have been situations such as the following, where their child has passed away, or it's a second marriage, and again they're very adamant about having a normal pregnancy. And we have faced patients who's come back for religious reasons, or even what I've mentioned here, to reverse effects of the post-tubal ligation syndrome. So there have been various techniques when it comes to tubal reanastomosis. There have been one-stitch technique. They've used titanium clips. They've used fibrin glue. But none of those have given you a very good outcome. And there've never been a standardized technique in doing a tubal reanastomosis, which can be easily duplicated. So when it comes to instruments that we use for reanastomosis, it's usually the two lateral ports are usually 3 mm ports, and we do put a 5 mm port suprapubically. And we basically use atraumatic graspers, which has got a good grip without much slippage. So we use co-designed type of needle holders here, 3 mm ones. And the sutures, so initially we were doing simple sutures, but then now we have changed to barb sutures here. So here we use 5060 barb suture for the tubal reanastomosis as such, and we use a 60 proline for approximation of the mesosalpinx. So basically, when you're doing a tubal reanastomosis, your biggest concern is how you do things without much of a pressure on the tubes or the tissues that you're handling. So you have to do a very small movements, very precise movements here. Sometimes you even have to hold your breath so that your body is not moving. So the sutures, when you take through the tube, through the distal and the proximal tube, the one thing that you have to keep in mind is it's always, when you start out, it's always from the outside to inside. In this picture, as you can see, you take a outside-inside suture at the proximal side, and then do a inside-outside suture on the distal tube, so that the knot comes out on the outside of the tube, not inside the lumen. So here you can see a magnified image of a barb suture here, which is, so this is the biggest advantage of barb suture here is the fact that you're avoiding taking knots. The knotting itself can cause, if you're not very careful, it can cut through the tissue, or if you're tightening it too much, again, you're hampering the blood flow to the tube. So barb suture has, for us, we have been doing it for the last few years, and then this has given us a very good outcome. So this is a video of tubal reanastomosis using barb sutures. So 30-year-old P2L2 with a history of 2 previous cesarean. So she wanted to do with a history of lab sterilization, fallopian. So here we are using a 26 gauge spinal needle to inject vasopressin into the mesosalpinx. So this helps out in the by decreasing the blood flow there. Bleeding and everything is decreased here. And we use a 5 mm scissors to cut the tube, freshen the edges. First we cut the serosa and then the lumen as such. And then we inject dye using a Spackman cannula from below, and make sure the tube is, the proximal end of the tube is patent. Now we are going to the distal end, where you are again cutting the serosa first, and then the lumen. And we use a chromoperturbator to check the patents here. You can see the dye spilling out from the fimbrial end. So as I mentioned, we are using barb sutures here. So I think the quill ones, which comes out with needles on both ends. So what you can do is you can cut in the center and use it as 2 sutures. And first we take a bite with a proline, 60 proline, along the mesosalpinx to approximate the tubes. While you're doing the tubal reanastomosis, you don't want excess amount of traction on either end of the tube. That can cause cut through on the tissue as well as cause further bleeding. So this stitch on the mesosalpinx helps in approximating both the edges. and makes it much easier. So this is a normal one. It is not a barb suture. So you do have to do your traditional suturing, knotting here. Now, so the next step would be our suturing with the suturing of the lumen. So usually with barb sutures, we take sutures at 6 o'clock, 3 o'clock, 9 o'clock, and 12 o'clock position. So here you can see a 6 o'clock bite on the proximal end, outside to inside. And we have put a small knot at the end of the suture so that it doesn't come through. So initially we are taking a bite through the serous, and now we are going through the tube as the lumen. Now going to the proximal end of the tube. One thing that you can do is constantly while you're doing the suture, you can ask your assistant to push the die so that you can visualize the lumen much better, and you can make sure that the tube is also staying patent. You have to be very careful in pulling the sutures. There shouldn't be excessive amount of counter traction either. So carefully pull it, make sure it doesn't cut through. Now we are going through the 3 o'clock suture at the distal end, and now you can see how we are constantly pushing the die to identify the lumen. In some cases, you may not be able to identify the lumen that clearly, especially in a very stenosed tubes. So we are using the same 6 o'clock suture, which continues onto the 3 o'clock suture. So the advantage is that we don't have to do a knotting at 6 o'clock at the suture and then go for another one. So now we are finished with the 6 o'clock and 3 o'clock. Next, we are going ahead with the 9 o'clock suture. So barb suture as such has made things much easier, especially for surgeons like me who are starting out, who's got far less experience compared to all you seniors in this event right now. So although I am quite good with knotting, but this does save you a lot of time and energy. And when it comes to microtubule surgery, it is quite a difficult feat doing suturing as such. So barb suture is quite a boon to endoscopic surgery. Now you can see after the 9 o'clock suture, we are continuing the same suture onto the 12 o'clock one. Again, we are pushing the die, making sure that the tube is patent. So make sure that your first suture is also not tightened. You have to tighten both the tubes along the same time so that you do get a proper orientation of the tube. If you tighten the first one in the beginning and then try to do the other one, you may have a rotated tube here. So make sure the orientation of the tube is right. And we're doing a chromoperturbation here, and see you can identify the spill from the end. You would definitely end up seeing a bit of leak from the reanastomosed area, but that is not to be a cause of alarm. It does occur, but then once it heals, it shouldn't be a problem. So now you can see how we are suturing the serosa here. So first we are doing the 3 o'clock here and then going to the 12 o'clock. And then usually when it comes to serosa, we usually don't put 4 all around. We make do with 3 sutures here. Still, we do get a good watertight suturing with the tube. So the key words when it comes to tubal reanastomosis is being precise and being very, very careful. Not to give an excess amount of pressure on your instrument. If you are finding it difficult to unlock your needle holder, ask your assistant to unlock it without moving the needle holder much. Make sure your camera person, everybody is doing a very precise and a very slow and a precise movement during the surgery. So in this patient, we have done a tubal reanastomosis on both the sides, the left side as well as the right side. You can see how there is spill from both the sides here. So this is an older video where we were using regular sutures instead of barb sutures. So it's pretty much the same mechanism. I'm not going through the entire video. So steps are almost the same, not much of a difference. except the fact that you're doing the sutures through each position individually. You're not continuing the same suture to the next position. So we're doing a 6 o'clock suture here, doing a knotting. It's a double knot. Make sure you're not giving an excessive amount of pressure and cutting the blood flow to the area. So here, yeah, once the knotting is done, you cut and then go to the next position. So it's pretty much the same principle here, same as bar suture. You are suturing the serosa. You can see the spill from that end of the tube. So success of tubal reanastomosis, the major factors are the age, the technique of tubal ligation. If you don't have, if you're doing, usually with modified polymerase technique or fellow ring ligation, it's usually we can usually do a good job with reanastomosis. And we are usually, hoping for a ischemic reanastomosis, not towards not the Cornwell implantation sort of technique, which has not shown a very good success rate. And the diameter of both the tubal ends should be of equal size and sufficient size. And the length of the remaining tube should be at least 4 inches after the procedure. For us, since my father has been doing this for a very long time, and we've always seen a very good outcome, almost comparable to the literature, what is available. So we're getting more than 50% of success rate, but then over time, since the last few years, the need for tubal ligation, or the patients that are coming for tubal tubal reanastomosis has significantly come down. So it's previously we used to have one surgery every month, but then now it's usually one every few months.
Dr. George, if you can wind up, please.
Yeah, this is my last slide, ma'am. So that is our experience with tubal reanastomosis. And once again, I would like to thank everyone for this opportunity.
Thank you, Dr. George. That was a lovely presentation on tubal reanastomosis. And we missed your father, but you've done justice to the talk. So I think that's very commendable.
Thank you, ma'am.
Niranjan, you want to take over?
Yeah, I feel, thank you, Dr. George, for being there with us. And I hope everything will be fine very soon. Take care. It was a wonderful presentation. You're carrying on the legacy of your father, and I'm sure you'll be doing a wonderful job. I want to tell everyone that we have got not only people from India, but we have got people who have logged in are from Nepal, Sri Lanka, Bangladesh, and even luminaries who are at the helm of affairs of organizations, and members who are very senior in endoscopy, who are really locked in and hearing all this discussion and the lectures. So I'm really happy to have all of you being together on this weekend where you're given your valuable time. Sarita, I would request you now to introduce the next speaker, Dr. Sarita Bhalerao. I think Dr. Pratik, you can take over from here, sure.
Thank you very much, sir.
I would like to introduce Dr. Pratik. Thank you, Sarita, for that wonderful moderation. We will catch up with you and Dr. Sunita as soon as he returns. I would like to introduce now the young and dynamic member of the Managing Committee of Mumbai Obstetrics and Gynec Society. In addition to that, he is also the AMOG's chairperson of the Endocrinology Committee, and also was the FOXY chair of I think endocrinology committee. Yes, but he does a lot of programs on endometriosis also, so that is the reason with two he's being there. And well, he has taken training from many countries. We can see his biodata is full of chapters, lectures, and publications, awards. And as a person, he's very hardworking and really doing good job for the Society of Mumbai and Foxy and Amox. So with this, I would like Dr. Pratik to please take over and moderate the next session. Thank you so much.
Thank you, Dr. Niranjan Savan and the organizers for having me here. Thank you so much for that kind introduction, sir. Can we have Dr. Anshumala Shukla Kulkarni's slide, please? It's my proud privilege to introduce Dr. Anshumala Shukla. She is a consultant robotic surgeon at the Kokilabin Dhirubhai Ambani Hospital in Mumbai. She has a clinical fellowship in advanced gynecological laparoscopic surgery from Sydney. She is also the proud possessor of a clinical fellowship in minimally invasive surgery at KK Women's and Children's Hospital in Singapore. Her special interests are advanced gynecological laparoscopic surgery, pelvic floor reconstructive surgery, excisional endometriosis, and robotic surgery. She is here today to speak to us on robotic surgery in gynecology. Madam, the stage is yours.
Thank you very much, Dr. Pratik, and thank you, Niranjan, for inviting me over and giving me a chance and opportunity to share this relatively new, not so new, but definitely a little controversial topic with regards to application of a new technology in minimal access surgery. I'm going to start sharing my screen now. Just give me a second. There, right. Right. So is my screen visible?
Yes.
All right. So, like I said, we're going to speak about a relatively new and probably less understood new technology in minimal access surgery, which is one of our miracles of modern technology. We all know that less is more, and we've always tried to reduce the port size, reduce the camera size, reduce our hysteroscope size. I've been listening to fabulous lectures on hysteroscopy past, and I think we are all trying to do as less minimal access as we can possibly get. And I think robotic assisted surgery is one of the newest revolutions that could have come to take over all of the disadvantages or adjustments that we had to do as a laparoscopic surgeon to be able to achieve a very good clinical outcome. It was approved way back in 2005. It's almost been 15 years since it has been used across the world for gynecological surgeries. A lot of news it had created when it actually came out. Everybody was talking about a new system. There was a lot of talk about whether this is going to be a robot which is actually going to walk in and do surgery, or is it actually the surgeon who's doing the surgery? Is it going to take over surgeons, and is it going to be that we will not be needed anymore? Well, none of that is true, and we have now close to, in fact, 100 plus health facilities across India who are doing high-end robotic surgeries. And it is pretty much in Mumbai itself. We have now 11 hospitals in Mumbai who have the Da Vinci robotic system. And there are newer CMR robots coming in, and there are at least two centers in India who have actually used the CMR robot already, the newer one that has been FDA approved as well. So the robots are pretty much now slowly creeping in, making it possibly marketable and very but viable for us to adopt to this technology as well. The procedure growth in India has been phenomenal. When it started off in 2011, 871 cases. As of date, the data that I asked the rep of Da Vinci to see, he said about 40 to 50,000 procedures have been conducted in India for robotic surgery in various specialties. So the growth is phenomenal. It's definitely taking it up. And as you can see, gynecology forms a very big part of those people. So it's generally urology that is growing, but gynecology, especially benign and oncology, have actually taken over a lot of these things. Our complication rates are very competitive. In fact, much better than you would find with other methods of surgery. At Kokilaben Hospital, we started off our program in 2012, so we've completed 8 years now. We have been doing quite a good number of maybe fastest, the first cystectomy, the first sacrocolpopexy, first radical cystectomy, lot of other things that have been a lot of number of firsts that have been done at our hospital. We do have a very robust program of the robotic surgery at KDH. We've been doing hysterectomies, myomectomies, endometriosis, tubal recan, endometrial cancer, as well as cervical cancer. So even trachelectomy has been done. Possibly the maximum cases that are done are consisting of hysterectomy, as it would be in most other gynec procedures, where that takes away the major chunk of the surgery that we do. But we have done quite a few of complicated myomectomies, endometriosis specifically. We have a very large series of endometriosis, in fact, one of the largest series in India of robotic assisted endometriosis surgery that has been done, and pelvic floor surgery as well. The time that is taken to do this surgery is pretty much the same as what it would be in international benchmark. So we are not really, far away from this. This is probably our first 150 cases. We've gone beyond 500 now. But you can see that even in those first 150 cases, we were not very far behind from laparoscopy in terms of time. The setup time that is required to set up the robot also is now cut down to a hardly 5 or 10 minute procedure. It does not take a very long time when you have a good team in your thing. So the myths that are associated with robot assisted surgeries are that it's time consuming. It has a longer learning curve. Do I really need it? It's very expensive. It can cause complications. And sometimes it's like maybe, this one's doing robot surgery and maybe that is the reason why I should be doing robot surgery. But that's not true because, if you are wondering if you should be doing robot surgeries, you must think about the fact that are you trying to convince me or are you trying to convince yourself? So is it that when you start off the robot surgery, sometimes you wonder, should you be doing this surgery? And you try to think, I mean, when I started off the surgery, I had to really think when I was doing so much of laparoscopy already and I could do everything. Should I really be doing robot surgery was something I always had to convince myself. And I think over a period of so many years, with the first-hand experience of both laparoscopy and robot surgeries, I have netted it down to a certain indication which is very good and should specifically be done with the help of robot. And there are some which can very easily be done with laparoscopy. And I would like to share some of that. So it's really not fair to compare robot versus laparoscopic surgery. Is pretty much like comparing apples with apples. It's just a more advanced method of doing minimal access surgery where your vision is much better. You see with three-dimensional, and the three-dimensional view is not like a routine three-dimensional view where you have optics which are far away from you and you're wearing the binocular glasses to be able to see the three-dimensional image in your head. This is an immersive view. This is a view where the images are collated and presented to you at a screen where you see it like you would see with your naked eye. This is an immersive view. You're not looking at something at a screen far away from you. When you put your head down in the console, you actually see like you would see in an open abdomen of a patient. The immersive view is far different in the way it gives a picture as compared to what a traditional 3D laparoscopy would be. The instrumentations again are like you would do it with an open surgery. You've got your wristed instruments, so you're able to move your hands and do surgery. You can pretty much mimic every single step of minimal access surgery with laparoscopy, or even better it, in fact, with the robot. And you are not standing on your feet all day. You could do 4-5 cases and not feel tired because you're pretty much seated and doing it well. So for me, laparoscopy and laparotomy, tying the knot, led to what is called as robotic surgery, or having the mesh machine available probably can help to make a surgeon the number one that can be there. How we started off the program was to be able to build a team. It's very important to have a primary surgeon identified who is going to lead the whole program as to who's going to do the surgery mainly. Because if you have too many people trying to do things, everybody gets confused. The ground rules need to be set. You need to have a set cohort of OT nurses, the physician, surgeon assistants, your surgical residents, fellows, anesthetists. All of these need to be together, because to have a very successful robotic program wherein you're not wasting time, you're able to efficiently do things, you're able to get your head load Trendelenburg like you would like to, you need a very good teamwork. It's very important. Of course, the assistant is now not really doing much active work except for doing a little bit of passing of suture or suction irrigation, and sometimes exchange of the thing. It's important in order to propagate or in order to understand robotics better. We across the centers are now doing a lot of data collection to see our data of robotic surgery. So whether it's across all the AIMS that are there in India who have the robot now, which is the XI robot, the SI robot, and the XI robot, which has a teaching console. So I've had the opportunity to go to two of the AIMS of India where I was a proctor to teach robot surgery, and it's amazing because here you're sitting on two different consoles of the robot, and me being the master console, I can actually take over from the person who's learning and move the handle and show them, look, this is where you need to cut it. So I mean, this is not just hold, just like how in open surgery you would hold a person's hand and say, no, not like this, like here. Like I would remember my teachers in KM hospital standing right, the two of them right next to me, and when I was doing my first vaginal hysterectomy, they actually would hold my hand and tell me, no, just put the clamp here, put the clamp here. And look, the robot was pretty much like that. I could take over the instrument and teach very well. And I think education is very important because adequate training is also very important to be able to use this technology very well. And we are obviously going to do a lot of feasible studies in this as well. So instead of an enabling technology, robotic gynecological surgery is more of a facilitating technology, which means you can already do a laparoscopic hysterectomy. It is not that it's allowing you to do it through minimal access, but it's helping you to do it better. I think that's how you should think of robot-assisted surgery. We've done robotics in almost all the fields that are available, and numbers, of course, are going ahead. It's a very efficient system. Ergonomics are amazing. So you can see here that I'm seated here and I can have the machine move towards me. See, it comes up to me and I can be seated with my arms rested, my back straight, with minimal strain on my neck, and keep operating for as many hours as I like. What is the learning curve for robot-assisted surgery? The immersive environment with the three-dimensional views actually does not take a very long time. And if you see the amount of time required in the first few cases, you'll find that the time starts improving. So a learning curve for somebody who does good laparoscopic surgery, I would say, is 25 cases. If you've done 25 cases which are proctored or guided, you are good to go. That is the international way in which they say you can do robot surgery. And for those who've never done laparoscopic surgery, it's a 50 cases that initially that you need to be monitored or mentored about. And when you start off with doing any surgery, you first think that you don't want to do it because it's a challenge. Then you think maybe I can't do it. Then maybe you feel like maybe I should do it. Start wondering how to do it. Try it, then you can do it, and then you can do it. So it's all about that. And it's best for obese women with endometriosis. You find that all of the factors of endometriosis, a very vascular disease, having a lot of fibrosis, distortion of anatomy, doing good excisional surgery for endometriosis, being able to remove every single piece of endometriosis you see in the pelvis, and doing precise dissection. All of this is amenable to doing what is there in laparoscopic surgery. Out of all of those complex cases of endometriosis that we've done, we've had one ureteric injury and one bowel injury out of the cohort of almost 240 such surgeries. So it's not, it's pretty much with the international standards of issue. So it's not really been there. And we've used ICG dyes also. So there is a system called the XI in robotics, where you use a filter. This allows us to see ICG, which shows up in red fluorescence light. The green filter allows us to see the ICG in the blood, and it can actually help you to identify endometriotic deposits in the pelvis. It helps us to improve our precision of dissection as well. There are various studies where they've used ICG for doing peritoneal endometriosis excision and found that they actually gave you a better histopathology result. It helps us to improve the intraoperative diagnosis of endometriosis, and of course it allows us to good dissection even when there's a lot of fibrosis seen. Dr. Nezat himself has compared robot-assisted surgery versus laparoscopy for endometriosis, and he felt that it definitely gave an advantage over laparoscopic surgery. With regards to hysterectomy, when you're doing it, look, you don't want to do a simple uterus with a hysterectomy because it can be done very well with a vaginal surgery or with a routine laparoscopy. You're looking at using this technology to do something which may sometimes get converted to open if you're doing a laparoscopic surgery. For example, multiple surgeries before, or a very large uterus, or an oddly placed myoma, or a grade 4 endometriosis. These are patients who will require or will benefit from this technology, and I strictly restrict my use of robots. So my robotic surgery percentages out of my entire surgical profile is only 20%. So 80% of my work still remains laparoscopic. But those people who actually need it will be the ones who've had previous surgeries. There's patients who've had bladder repairs done post cesarean section, who have had pelvic inflammatory disease, ovarian abscesses, multiple laparotomy done. These are patients whom you are always worried and concerned about being able to do a successful laparoscopic surgery, and robot has actually made it facilitated us to be able to do it very well. We've done it for large uteruses also. So again, here the camera has a 10-time magnified view, but it can be used very effectively to be able to go ahead and do larger uterus surgeries as well. When you're looking at myomectomy, multiple myomas which are deep inside the intramural with a huge intramural component, or a submucosal, intramural, subserosal, large myomas, the dissection for these surgeries are actually very good. What's peculiar about doing a robot-assisted surgery is you can actually now look at the pseudocapsule very clearly. And it's important to be able to preserve this capsule because that is where all your neurovascular tissue structure around the fibroid exists. Preserving this capsule helps us to improve the healing of the myomectomy scar on the uterus. And, with the visualization with the robot, you're actually able to do this much better. You can always have image integration. So if you've had an MRI done as a preoperative imaging for multiple myomas, you can, while you're doing surgery, actually have a picture of the MRI right there in your console, in your view, with the uterus next to you. And you can map yourself to say, okay, this is where the fibroid is located, and that's where my incision should go. The next place where we use is what is called a sacrocolpopexy. Use of mesh is now limited only to doing sacrocolpopexies, and again here being able to successfully apply sutures over the anterior longitudinal ligament is possible with the help of the robot. So you can see here a video where we're doing a sacrocolpopexy and a paravaginal repair. So we don't have haptics in robots. So if you see here my instrument, I am not able to make out if this is actually solid or it's not. So the way of doing this is by a visual clue. So I move the peritoneum to be able to see how much I can look in and make out where the sacral promontory would be to be able to open the peritoneum. I open up the anterior part of the UV fold, push the bladder as far out as I can. This is best done when the uterus is intact rather than after the uterus has been removed on the vaginal vault, because the cervix actually gives you a good platform over which the UV fold and the bladder can be pushed down far out to be able to get adequate space on the anterior vaginal wall to place your mesh correctly. So this is again done through there. So we finish off the hysterectomy, post which we do the dissection of the rectovaginal septum. This is levator and nice sutures that are being put in. This is for a sacrocolpopexy. Here, of course, again, dissection of the bladder over the vault needs to be done carefully so there is no damage done to the bladder. You need to open up enough space to be able to push, place the mesh. Open up the retroperitoneum. Place the mesh over the anterior as well as the posterior part of the vagina. The sutures have to be placed such that the mesh is evenly placed all over the anterior and posterior vaginal mucosa. So you can see here that we place the meshes, then we place the mesh over the sacral promontory. We push the vaginal vault as much as we can, and we are able to place the suture over the anterior longitudinal ligament. Retroperitonealization of the mesh is obviously mandatory, and again you can see how the instrument has a wristed movement which allows you to place sutures quite easily. The outcomes have been fairly good and comparable to laparoscopic. The only advantage they found was in obese patients, and that it was far easier to do the surgery, as well as the time required was much better. Our experience has been pretty good. We've not had any recurrences so far, and out of the robotic surgery that we've done, we've not had anybody having any recurrences or any mesh erosions. And Da Vinci is actually known to help in doing laparoscopic, sacrocolpopexy surgery. Tubal reanastomosis, there are a lot of data that says that it may not be advantages in approximation, but definitely helps us to reduce, as compared to a laparotomy, helps us to have a faster recovery, and a good micro surgical principle can be applied. Adhesion prevention is definitely there with robotic surgery. So it basically offers us many new advantages in the field of gynecology, but it has to be used in the judiciously in the correct patient setting. This is also possible to do single site surgeries with robot assisted surgery, where you have a port and the camera. Of course, the system here already has angulated instruments, so manipulation of instruments and angulation to be able to do a surgery is very easily done with the help of the robot. It's extremely useful in patients who are very obese, because here the robotic arms actually act like a lapro lift. Literally, they are picking up the abdominal wall and lifting it up a little more, and the amount of pneumo required is not there, because we use certain almost 45 degrees of Trendelenburg with good amount of support to the patient. It's possible for us to do this surgery even in very morbidly obese. My personal highest BMI has been a BMI of 40, where I have operated on a hysterectomy, BSO, pelvic lymph nodes for endometrial CA patients. BMI was 40, but it went off very, very easily without any issues. So you can see that cost seems to be the only deterrent, and I think with the advent of newer robots, this might actually come back. How we can allow robotics to get better is by giving a package to the patients. The patient is never worried about the billing. We reduce the ports, so to reduce the costing, we have the capability of using 3 hand instruments, but I cut down on one instrument. For the last almost 6-7 years, I have not used the third arm. I just use the 2 arms. I'm able to do the surgery very well by, because that helps me to cut down the cost of using the robot in surgery. Trying to cut down on other things like using an indigenous endo bag, advanced electrosurgery is really not required, because you're able to see very well. So you're cutting down the cost of harmonic scalpel or a smart bipolar, and your patient doesn't require as many analgesics. So you're actually able to cut down the cost using these other indirect methods. The port placements are like this, where you could either have them all in a straight line, or you could have them in a W pattern. This is again a paravaginal repair being done for robotic paravaginal repair being done. So dissection in a narrow space. Again, here the advantage is that you're able to dissect well. I'll please scroll through this, since we are, I know, running far behind schedule. So you identify the vagina and the lateral iliopectineal line, place sutures to be able to hitch the vagina up laterally to the ligament. So again, here you can see that narrow space suturing becomes far easier with the use of the robot. So you allow the assistant to push the vagina up, and you pull the vagina up in this manner here.
Sorry to interrupt, you have 2 minutes to go.
Yeah, I'll be finishing soon. Going on to just show you a myoma, you can see here this is it's a large myoma which is extending from the serosa intramural up to the submucosal part. Here, the method of doing a myomectomy is not by a traction; it's more of a dissection. So we burn and cut and burn and cut. It is never just an avulsion or a traction and removal of the myoma. The advantage I feel here is that, like I said, we preserve the pseudocapsule. Also, if it's a submucosal myoma, as you can see here, we will be very precisely able to control bleeding because we're using electrocautery and dissecting it. We are able to therefore use, minimize the bleeding very much. And you can see that there's the endometrium which is popping out there. And I'm able to cleanly dissect this myoma off before I start placing sutures. So this was a myoma which were extended all the way from serosa right up to the submucosal component. Again, when you come to suturing, this is placed in 3 layers. I would still use a vicryl suture in the internal layers and reserve the barbed ones only for the serosa in a baseball manner. That just helps me to apply figure of 8 sutures which give me good hemostasis. And then going on to so you can see here we start off with a barbed suture and do a baseball stitch so that there's a good reconstruction of the uterus happening here. Right, the docking is done through central. We can also do a side docking, so we have the space available for the assistant to be there on the vaginal end. I hope that we can sometime make a robot in India and basically allow us to be able to do surgical procedures very well. Maybe we'll have the surgery robot coming in and doing rounds for us, or even have surgeries being done at home with the help of the robot kit. This is the Da Vinci Xi. Very quickly going to show you the newer robot which we have. We have 2 of them. We have SI and XI at the hospital. And I've used both of them. This one actually has targeted placement of ports. So you just place the center port targeting on the anatomy where you want to be. Arms adjust themselves on their own and would actually, give you the correct position of where your port should be. This is a fantastic robot because it allows you multi-port surgery. So if you see here, you'll find that with this, because there are only 8 mm, so you can see here I can do a targeted approach. I bring the cart in and I target the main camera head at my anatomy, and then the arms just adjust them. So that's the laser targeting that is happening there. These are all 8 mm ports, so they are not the traditional 12 and 8 that we would say that the ports are bigger. These are all 8 mm, and I can put the camera wherever I want to. So I can do multi-port surgery. I can do surgery from the right quadrant, from the left quadrant, from the suprapubic area. I can move my instruments as I like, and it just kind of adjusts itself accordingly. So we are basically going to be looking at reasons why you should do robot-assisted surgery. It is highly precise. It can be used for a large variety of surgeries. It is definitely less painful because the ports are far lesser. The instruments are moving at a pivoted point on the abdominal mass. There is no traction on the muscle or the abdominal wall, unlike laparoscopic surgery. There is much lesser blood loss, quicker recovery. It magnifies, it is 10 times magnified view with an immersive 3-dimensional view. It definitely reduces chances because it allows you to scale down your movement. So you can scale down your movement from 1 centimeter to 5 millimeter. So you can filter out all the tremors. It makes us the surgeon much more comfortable. It is definitely cheaper than it is abroad. For sure, we are doing this surgery at a far, far discounted rate as compared to what it is available across the world. And it's available pretty much everywhere. So I think the way forward is to identify hospitals that can sustain, which have a multi-speciality system so that the robots can be used correctly, create awareness. Credentialing of surgeons is very, very important. It is important to be able to get good mentors to teach and make sure that the robot is being used correctly and have good training centers. So like I say, at first they will ask you why you're doing it and later they'll ask you how you're doing it. Thank you.
Thank you so much, Dr. Anshumala. That was, I think, amazing and a fantastic coverage of so many different surgeries in such a short time. Apologies, we had to cut you short. Maybe we'll have you another day to deliver a full masterclass on the Da Vinci robot.
I'll
It
be
was
happy to
amazing
do
to
that.
see. Thank you so much.
Thank you.
Thank you, Dr.
Thanks, Niranjan.
Anshumala. It was a wonderful presentation. And really, you are so busy. I know you are in the operation theater at Kokila Ben. There are so many procedures which are happening, and marvelous work you are doing in KDA Hospital, Mumbai. And I think you have made a niche of robotic surgery in your area. We are very proud of you. And I can tell you, we have got more than 1800 members which have logged in, and they are still there, and they are waiting now to hear. I hope this recording is available. If it is available, I will surely share this. So thank you for your valuable time. And Dr. Pratik Tambe, thank you so much for
Thank you,
moderating
Niranjan. Thank
this
you.
session. Thank you.
Thank you.
Pratik, go ahead. Well, I will be introducing Dr. Prakash Trivedi. The host will be last, and that's what we are. We will be there till the end, and we want to give you the best. Endoscopy for all, endoscopy for every gynecologist. This word was coined by none other than Dr. Prakash Trivedi when I had the opportunity to do an IAGE conference in 2014 May. I exactly remember those dates, 10th and 11th of May, where we had luminaries from all over India which had transcended to Mumbai city, and we had a wonderful time for the next 2 days. And that's what, with that vision, I went ahead, and that's what I'm carrying the vision of Dr. Prakash Trivedi when he was at the helm of affairs as the IAGE president then. We had the blessings and the privilege and the honor to have felicitated all the past presidents of IAG, and I want to give them that name and recognition, starting from Dr. Shraddhananda Thakur, Dr. Rakesh Sinha, Dr. Rishikesh Pai, Dr. Sham Desai, Dr. P.K. Shah, and we had also then Dr. C.N. Purandare sir as a FIGO president being the chief guest of our function. So with this introduction, I want to introduce my guru, my mentor, Dr. Prakash Trivedi, along with Dr. P.K. Shah sir, which I had the opportunity to learn endoscopy in 1991, 1992, when I was posted in Rajawadi Hospital. Along with sir, I had the opportunity also to work with Dr. Prashant Mangeshikar, and these were the two big doyens which started doing endoscopic surgery too vigorously, and it spread all over India like fire. And I'm amazed that sir is such a nice and caring person that he is always doing something new or the other. From endoscopy, he went to Brazil, he went to South America, he learned cosmetic surgery during the 2000s. He came back with an infertility committee as a chairperson in Foxy, and then we know the history which he made, where he got the maximum number of votes for the Foxy elections. And he is still there as the torchbearer for the IAG Foxy, and right now he is currently the ISAR president. So with this introduction, sir, I hope if I missed anything, please forgive me. I want to call upon Dr. Prakash Trivedi, sir, to go ahead and do his presentation, which is very rare. Documentation and publication. We do many surgeries, we do many operations. We have surpassed, Indians are galaxy of endoscopic surgery, but we lack in that documentation and publication. And I'm sure after this revealing lecture, which will be an eye opener for all the endoscopists, from tomorrow, you're going to start doing publication and documentation. Sir, I spoke too much, but my heart is pouring heart, and those are emotions with mind been working together. So please, sir, go ahead with Indian MAS skills are under documented and less published. I present to you Dr. Prakash Trivedi, sir.
Niranjan, I hope you are hearing me.
Yes, sir.
Yeah. It was lovely to hear Krishna Kumar. It was lovely to hear Anshumala. And I had a innovation program which was supposed to be tomorrow. But that is the Foxy meeting. Being past president, I thought I cannot clash with it. So we had innovation today. We had 3,148 people. Sorry that we had to distribute the crowd. But when Niranjan says, I can't refuse. There is no debate about it. And it was lovely to hear Anshumala. The question to Anshumala is whether people are paying more focus to robot or to Anshumala. This is what I told to Catherine in USA. But it was a wonderful talk, and I will go to the subject because people are hearing, and it's a scientific session. And we have to understand, even Kamran Nizad used to tell Indians have the skill of removing tonsil from the vagina without making noise. And there were few of us who went and told we can remove elephants out of abdomen. And the amount of work which we people do in India, we are very proud. And we are so proud that we had one AHL in 2016. We'll have one more AHL in 2021, to be precise, on 23rd to 26th September. But I want to take you to a journey which is very important for people to register and remember and emphasize. Now we always tell, is our teacher bigger or are our parents bigger? Parents gives us life. Teachers gives us ways of living. Teachers makes you think. And that is the greatest optimism. And I always believe, whether a year or decade, I don't bother about rice, I don't bother about tree, I bother about a lifetime. Educate people. The moment you educate people, today I, for the first time, told how you can do laparoscopic surgery in COVID times, which was 5-6 months such a top thing with me that I didn't want to share with anybody. Now you have to remember, all of us, or everybody sitting here, I have been resident, registrar, lecturer, etc., etc. We do have this phase of a glorious gap. And I always feel these gaps are given by God, giving you an idea that stop doing only deliveries, stop doing only suturing, episiotomy, cesareans, stop doing only lap TLs, start thinking something more. And that gap I had in 1985, when one of my very close friend Rakesh Sinha used to tell, "Kahan tu sonography seekhne ko jata hai?" We don't have any bearing of starting a clinic. And I went to father of sonography, Hemant Shah, for a month's training. From 8 a.m. to 2 to 3 p.m., I used to watch this master doing OBGYN sonography, ophthalmic sonography, thyroid, abdomen, scrotum, soft tissue. And as a person I was, when I come back, 5 to 10 daily I used to read sonography. And next month the student didn't come. So I was happy to have one more month. Third month, he was so happy to make me his locum when he was going to USA. Now that is no less than a medal to me, a person trusting to me from thyroid to pelvis to scrotum. It is not possible. Jawahar Modi was with me. 1987, I think so Asha Dalal, Sudasha, Dr. Rawal, and everybody will remember that I was in charge of sonography, whole department. 70 to 100 sonographies per week. I was very happy because at that time I was young. So I published the nomograms of fetal weight in Jogi journal. Because I thought that how can vitamin D be a standardized level for everybody in the world? Because the diets are different. From there, our journey was very interesting. I had a friend of mine who wanted to take pediatrics. I was first in medicine. And I told, why are you wasting your time? So he told, I didn't understand. I told, look, my role model is senior Dr. Tang. And what are you going to do in pediatric? Sounds slow. What is the complaint? So I pulled Rakesh from not going, where I was getting pediatric, into gynecology, and which was the biggest thing I did in my life. 1992, me, Rakesh and Prashant, three of us went abroad. I got trained in Clermont-Ferrand under Professor Brua. Prashant has his own history. Rakesh went to Adam Magos. And when I was coming back from Clermont-Ferrand, Professor Brua made a statement. Oh, well, if you don't have an endomet and if you're not going to prepare endometrium, the Trivedi, before he could complete his statement, Arno Vatis immediately is a very smart person. He was there. He told in French, okay, sir, you don't worry. This gentleman, 3 days back, has done an home pickup with 15 follicles and getting 14 oocytes. So he'll find out a way. Now it's very important for people to know Hamu's endomet when it was there. So me and Rakesh are roommates, batchmates, whatever our level of understanding was beyond the imagination of any most intellectual person. We started seeing Pfizer back. So I thought, okay, a company is making endomet. Let me ask them. They didn't know what is the pressure. Then I contacted Professor Hamu because my training was in France. He didn't know what is the pressure. So two of us, Indian, sat together and decided, okay, 120 XYZ should be the pressure for resectoscopic surgery, little lesser in the remaining thing. We have one brilliant brain. I think so. I saw Nozer talking. I think so. We were together yesterday. He used gravity. He used gravity with the same success. The beauty is the continuous flow diagnostic sheet with all of us use was designed by me in 1993 with one of the local company. In 1985, when I became board member of ESG, Sybil Stores was with me, and it was a Hamu's diagnostic sheet which was released in 1995. And she very smartly told, big brains think the same. At the end of the day, Indian gene comes in. So I told, madam, I thought in 1993. Europe thought in 1995. But I am happy because, they have to name an instrument on a name which sells. Hysteroscopic TCRE, probably at that period of time on unprepared endometrium, was acknowledged by ESG. I got Pramila Bhatia Award from prestigious MOGS, Foxy Korean Award of Young Scientist. And at that period of time, me and Rakesh were packed into the cavity. So we were the two hysteroscopists who were doing. So this is the continuous flow diagnostic sheet. This is the endomet wherein the company, nor the innovator didn't know how to use it. Now we have office hysteroscopy. I'm not going to detail. Kumar has spoken. So I'll move further. Now, without doubt, whatever procedure is done, this procedure in 1997 with Cook's Novice Scout catheter, we had 50% pregnancy rate, 70% bilateral patency, and 90% unilateral patency. This is one of the most common and important procedure which was done, apart from so many surgeries which we did in hysteroscopic surgery. But we have to remember, hysteroscopy in the world owes a lot to India. These are the different hysteroscopic surgeries which I will not go into detail. In 1995, we were very irritated. We were doing LAVHS. I think so. When I remember Dr. P.K. Shah had gone incidentally for breastfeeding aspect in US. And at the same time, when we had an event, Niranjan will be remembering, we had an event in Zion Hospital. So that is a whole workshop which I conducted. And I was constantly thinking, what to do about suturing. So in 1995, when my paper was accepted in Europe, so I first went to Nizat, and Harirish changed his program. Then I went to Harirish because he at 1995 was the first person who did laparoscopic hysterectomy, one person who will only operate with one sister and two ports. That's the time I designed a thread carrier, a knot pusher, and the closed knot pusher was so popular. I will show that point. Subsequently, 96, 97, as Niranjan pointed out, me and my colleague friend Prashant, not many people know, we were in the same unit. And by ipsilateral suturing, Charles Coe, Greg Cario, and us, we revolutionized the entire ipsilateral suturing. Then laparoscopic birch. I was so happy to see George Paul today, because George Paul was so impressed, PG Paul was so much impressed in 1997 event we had. So I did my first laparoscopic birch, tubal anastomosis, and all the people in India saw this. And not many people know that PG Paul lost his mother. That's the reason why he is not there. I'm very happy to see George Paul carrying the torch of knowledge which doesn't stop. As far as suturing is concerned, this is something important. This is a thread carrier which I designed at that time. It's like our port closure needle, because extracorporeal knot I designed. So this suture comes out, and this is our simplified Trivedi's knot, which doesn't give you any glitch like the Roder's knot. It's a very simple knot. If you know, and I used to always teach people, know one extracorporeal, one intracorporeal knot, you don't have to do anything. Though I knew 40 knots. So this can be pushed with a closed needle holder. And this closed needle holder, knot pusher, was designed by me. And by the time I release, 15 companies designed the same thing and went forward. So that is what I am trying to emphasize. We do so much of work, we do so much of research, we are least bothered about who takes the credit. Our point is very simple and clear. Let people understand. This is ipsilateral suturing. I used to constantly worry why we go and cross our hand and do surgery. And that is where I realized, let's do ipsilateral closure, suturing, wherein dominant hand is the right hand and less dominant hand is the left hand. And you can do suturing from morning to evening. And in those period of time, from I think so 1993 to almost 2006-07, I used to do minimum 5-6 surgeries per day. I never crossed my hand from right to left. So ipsilateral suturing was born. This needle holder were designed by us, right dominant straight, left with a curve. So it made suturing very easy and very simple. To give an example, when people went on telling that you're cooking the uterine, we did this ipsilateral suturing. So once you go through the uterine skeletonizing, then you can suture it. You can take an extracorporeal knot, you can take an intracorporeal knot. None other than Arno Vatius and Harirish till to date only does an extracorporeal knot. They don't do intracorporeal suturing. And they're very clear, they don't know intracorporeal suturing. India is a land where suturing was trained to thousands and thousands of people, and there's no debate that the best people in suturing, like vaginal hysterectomy, were through India. Then I got exposed to C.Y. Lu, and I owe my gold medal to Professor V.N. Purandare, because I had a case of urinary incontinence at that time. In 1983, he was shocked with somebody answering so well for urinary incontinence. Then when I went, then I started this laparoscopic birth. And laparoscopic birth, to be precise, laparoscopic birth was on 10th of January 1997. Another 10 days later, it was tubal microsurgery. This is Gore-Tex suture material, and it was one of the most exceptional surgery. And today, now I find I am still ready to do any birch, though we have designed many things. But if you tell to people to show a birch, people will run away. So you have to remember that lots of progress have been taken. Obviously, laparoscopic surgery was always a controversy. Going beyond the boundaries, the book I released with Kapil Dev, in terms of size, in terms of weeks, in terms of number, in terms of degeneration of fibroid, battle of bulge. I always tell the battle of bulge was always a challenge in India. I have few of my friends who have the highest weight of uterus removed, we may have highest weight of fibroids removed, highest number. In back, as far as it goes, nobody in the world even competes with us. But I'm very happy with people like Rakesh, people like Neeta, people like Hafiz, who were in the forefront of the Battle of Bulge. By Battle of Bulge, I mean they were not there to prove that, look, what I can do with my laparoscope. They were very sure. And I will tell you one principle with Dr.
Thank you, doctors. Thank you for your time. Thank you.